Will come to order. Good afternoon and welcome. Thank you all for joining us, and it's good to see such a good turnout of members today. While many of us are back here in Washington, we're holding this hearing virtually in compliance with the regulations for remote proceedings pursuant to House Resolution 965. This new authority has allowed us to continue to do our work while at the same time keeping our staff and families and broader community safe. It is a little strange to be doing this outside of Longworth 1100, but I think we're going to have a productive hearing. I know we're all still becoming more familiar with this technology, and so before we turn to today's important topic of nursing homes, just a reminder of a few procedures in navigating the panel. Consistent with the regulations, the committee will keep microphones muted to limit background noise. Members are responsible for unmuting themselves when they seek recognition or when they're asked to use their 5 minutes. Members and witnesses have their cameras on at all times. If you need to step away from the proceeding, please leave your camera on rather than logging out. Finally, it's my intention that we continue our proceedings without recessing. With that, let me present briefly my opening statement. On February the 27th of this year, the Life Care Center of Kirkland, Washington, reported the first major COVID-19 outbreak that resulted in 37 deaths. Tragically, this story quickly became a very common headline, and we know now that one estimate in the Wall Street Journal is 50,000 nursing home residents that have died, and most people seem to think that the number is far higher than that. Less than 1% of our U.S. population has accounted for nearly half of the COVID-19 deaths. To understand what went wrong and how to move forward, we invited CMS Administrator Seema Verma, the person responsible for overseeing nursing homes, to testify today. Indeed, she was offered dates and times of her choice this month and next month. She was offered the opportunity to come in person or to appear virtually from her desk. She could have offered a substitute, but this administration, which seems more terrified of transparency and accountability than COVID-19, has declined to provide any witness with the courage to face the responsibility for the thousands of deaths that have occurred. Following repeated unanswered requests since early June, we're now proceeding with today's expert hearing. We'll hear about years of regulatory rollback and relaxed oversight efforts that worsened a crisis that existed long before COVID-19 was a household word and left facilities really ill-prepared to deal with this current emergency. We'll learn from the on-the-ground truth tellers, a sister grieving for the loss of her brother, a licensed practical nurse who took it upon herself to purchase protective equipment with her own funds for her staff, and a local ombudsman who has been locked out of facilities, inhibiting her ability in California to assist residents in advocating for their rights, including preventing evictions to inappropriate settings like sending poor nursing home residents to homeless shelters, similar to the shocking report this past Sunday by Jessica Silver Greenberg and Amy Julia Harris in the New York Times that thousands of nursing home residents are being evicted across the country to homeless shelters and other inappropriate settings because there is a financial incentive for some homes to take more lucrative patients, including those who have COVID-19. We'll also receive insights from national experts who spent years studying the nursing home and both federal regulations and enforcement, and get their perspective on how the crisis is being navigated. Much of this crisis, I believe, could have been prevented by effective federal leadership. The Trump administration's response to the pandemic has really been the 3 Ds: denial, delay, and ongoing deception. But the overall performance rating is a solid F. Since the Kirkland outbreak, CMS waited 97 days, over 3 months, before it published the initial data about nursing home preparedness and infection. When they did publish, it was incomplete, riddled with errors, and they weren't interested in any of the data before the day that they issued the report. As local journalists have sifted through the piles of inadequate and inaccurate information, along with anxious family members, it's become clear that this was not responsive in disclosing the true scope of the crisis, where it's had the largest impact, and which facilities have been struggling the most. And to date, as of the day of this hearing, 800 facilities still haven't reported anything, including 100 nursing homes in Texas. And while we've known from the beginning that the essential tools to protect frontline workers are personal protective equipment, PPE, and comprehensive testing, it took CMS 80 days to have a single baseline test called for. And of course, that still hasn't happened in some places, and they did not provide the resources to do that testing, despite the fact that the Congress has appropriated $25 billion for testing and billions of other dollars that could be used for testing. And it took FEMA some 61 days, 2 months, to get out its directive concerning personal protective equipment for nursing homes. And when the equipment finally came from FEMA, much of it was junk that frequently was unusable, glorified trash bags as gowns, and cloth masks instead of N95 masks. Despite warnings since early January from health experts, the administration not only failed to invoke the Defense Production Act to provide the PPE that was needed, it was still, as data I've reported on and previously, they were still encouraging the export of massive amounts of personal protective equipment right into March. States and providers ended up having to fight for the scraps at higher and higher prices. Building on the oversight efforts of the Select Subcommittee on the Coronavirus Crisis, our hearing today is seeking some concrete solutions. We'll explore the regulatory, legislative, and enforcement changes necessary to protect the over 1 million Americans who reside in nursing homes. We'll also examine measures to ensure accountability when a facility fails a residence, including prohibiting mandatory arbitration clauses, as our colleague Linda Sanchez has proposed, and assuring facilities do not receive blanket immunity from wrongdoing. In some cases, responsibility for this catastrophe is shared with the administration by various failures at the state level. Texas, for example, has been hiding information about the identity of infected nursing homes and delayed testing and provision of PPE. Sometimes individual nursing homes were the culprits, and in other cases, I think the nursing homes were themselves the victims of administration indifference. I salute those homes that are doing all they can to protect their patients and their staff, but many of them have not done that, and some are still withholding information from residents and their families, including a call I received a couple of hours before this hearing from a woman who called about her mother. She learned that a staffer had been infected at the nursing home, but the nursing home declined to release any information about whether her mother had been exposed. This Congress should also accept a little of the responsibility. In recent months, we've appropriated huge amounts of taxpayer monies to nursing homes and other healthcare facilities without meaningful guardrails, knowing full well that these funds would be distributed by an administration indifferent to the well-being of residents and for whom accountability and transparency on any subject are absolute anathema. As Laura Garcia of the San Antonio Express News uncovered, $9.3 million was awarded, no real strings attached, to a San Antonio nursing home without a single COVID case, but a 1-star rating signifying much below average according to Medicare.gov, and which even under the very relaxed Trump administration enforcement had received 11 health citations on the most recent inspection conducted a year ago. This week, we've seen Life Care Nursing Home up in Massachusetts openly fire a whistleblower who spoke to Reuters about substandard conditions. And we really have no idea how nursing homes, which have received millions, have used those funds to ensure the protection of the residents and their staff. Hopefully today's discussion will offer us a little more understanding of the failures and the best path forward. And with that, I will call on our ranking member, Mr. Nunes, for his opening statement.
Thank you, Chairman Doggett. It's great to see you.
Good to see you.
Thanks a lot. Today we meet to learn more about the impact of COVID-19 on nursing homes. According to data from CMS, nearly 30,000 nursing home residents have lost their lives to COVID-19. That's 1 in 4 of the total deaths in this country. Other analysis has found as many as 43% of U.S. COVID-19 deaths have occurred in nursing homes and assisted living facilities. In my home state of California, CMS data shows we've seen nearly 1,677 deaths in nursing homes, about 30% of our state's fatalities. At a nursing home in Tulare County, part of my home district, 29 residents have lost their lives and 121 patients and dozens of staff members have been infected. This is a tragedy. For those continuing to live in nursing homes, including those who have recovered, life is different. Visitors are limited, windows come between moments of personal connection. Birthdays are often celebrated with drive-through parades. We've all been touched by the stories of workers who've sacrificed for the residents by isolating together in an attempt to keep COVID-19 at bay. We must act quickly to get this vulnerable aging population and the workers who serve them what they need to stop the spread and save lives. This Congress has worked on a bipartisan basis to invest in direct support to nursing homes and to increase testing for all Americans. While some governors increase the risk of COVID-19 infection for our seniors by requiring nursing homes to take in residents who test positive, decisions that our colleagues at the Select Subcommittee on the Coronavirus Crisis, led by Whip Scalise, are investigating. The administration has taken aggressive steps to protect nursing home residents and staff. They've issued guidance to increase testing in these facilities, improve infection controls, limit visitors, protect the financial interests of nursing home residents, and mandate nursing homes report cases of COVID-19 to all residents and their families, as well as directly to the CDC. Critically, CMS has announced the formation of the Independent Coronavirus Commission on Safety and Quality in Nursing Homes to provide a review and comprehensive assessment of the nursing home response to COVID-19 pandemic. This committee can and should provide a legislative path forward for the immediate future and long-term reforms to prevent outbreaks in nursing homes from happening again. I look forward to today's panel sharing their experiences and advice to help us do that. Some steps seem self-evident. When we have a safe and effective vaccine, vulnerable seniors and healthcare workers must be at the front of the line to be the first ones to receive this vaccine. Antibody tests must be accurate, and our scientists must keep their feet on the gas to tell us what, if any, immunity these antibodies might provide. Finally, the nursing home workforce must be protected with sufficient supplies of personal protective equipment. Before we hear from our witnesses, Mr. Doggett, I would like to make one process point today. We have 6 witnesses invited by the Democrats and only 1 witness invited by the Republicans. Though that is consistent with the committee rules, given the circumstances under which we're currently operating, I hope going forward, especially on a bipartisan issue like this one, we can see a more balanced ratio of witnesses before the subcommittee. But I appreciate your attention, Mr. Chairman, and look forward to hearing from our witnesses today.
Thank you. I'll be pleased to work with you on that witness issue. We're very fortunate to have the chairman of our committee, Mr. Neal, here, and I'd like to call on him for a statement.
And preparing for this hearing, which I think is critical to all members of the American family. I've been long concerned about the health and safety of millions of Americans who receive care in nursing facilities. Working very hard to get the administration to address gaps in oversight and consumer protections. The death toll in nursing homes during the COVID-19 pandemic has drawn to light the many challenges that patients and their families have been facing for years and years. I wanted to take part in this discussion today to speak to the desperate need for urgent action. Nursing homes have been the epicenter of this crisis since the first outbreak at a Washington state facility claimed the lives of 37 residents and staff members. In total, tens of thousands of lives of both nursing home residents and staff have been lost around the nation. This is nearly 1/3 of all deaths nationwide, and given the lack of adequate testing, these figures are likely to be gross underestimates. In my district, lack of staffing and quality issues led to an explosion of cases and deaths at the Holyoke Soldiers Home. 76 veterans died at the Holyoke Soldiers Home and more than 100 were infected, including my uncle, Bob Garvey. Yesterday's independent investigation report into this tragedy makes clear that there needs to be whole-scale accountability. I certainly endorse and embrace plans to renovate the Soldiers' Home, but at the same time to ensure it is treated with the same equity as its counterpart in Chelsea, Massachusetts. This is a seismic chore, and I am willing to help provide resources so that our state can move forward to rebuild these facilities and create a more transparent, healthy environment for our veterans who serve this nation with such valor. I also want to acknowledge the advocacy of the former superintendent, Paul Barabani, and he has made a number of suggestions which I have fully embraced, including that the Soldiers' Home needs to maintain the current number of beds at the facility. We are strongly opposed to attempts to downsize the facility. There also needs to be an adult daycare facility established on site, and Western Massachusetts needs to have a full voice in the discussion about the future of the facility going forward, making sure that not all decisions are exclusively made in Boston. Across the country, staff continue to report they don't have access to tests or personal protective equipment that they sorely need. There have been reports that PPE sent to nursing homes from the federal government happen to be inadequate for health settings. Just as the coronavirus has highlighted deeply rooted inequities in our healthcare system at large, it has also underscored the vulnerabilities in our nursing homes. The New York Times investigative report recently found that more than 60% of the facilities where at least a quarter of the population was Black or Latino, the COVID-19 rate of infection was double the rate where residents made up less than 5% of the population. This is hugely devastating, but we all know it's not a new problem. Make no mistake, what's happening in nursing homes, soldiers' homes across the country is no coincidence. It is the outstanding and long-standing deregulation campaign the Trump administration has waged against nursing home care for years. Their policies have exacerbated the already present safety threats to these residents, and thousands have died because of it. This administration has repeatedly weakened safety standards that have degraded care overall and made residents more at risk to infectious disease outbreaks. While they have taken some action to contain the virus and to protect patients and workers, they have not done enough. The HEROES Act, which the House passed over a month ago and this committee was much responsible for, includes responsibilities for the provisions of safeguarding quality nursing home care during the pandemic and strengthening protections for workers and patients. Advocates and healthcare professionals alike agree that the administration's inaction earlier this year has worsened the outcomes and fatality rates in nursing homes. Our committee stands ready to hold this administration accountable and demand they combat this deadly virus in nursing homes and protect the health and well-being of all Americans. With that, I yield back the balance of my time, and thanks to the subcommittee for undertaking this responsibility.
Chairman Neal, and without objection, all members who have written open statements will be made a part of the record. I'll also be making, as a part of the record, several statements that we've received in writing, including one from Sissy Sanders of Austin, who's led the fight to ensure that staff and residents are regularly tested, and has expressed great concern about the reckless and irresponsible action of the Trump administration in this regard. A statement from Brian Lee, a former ombudsman for the entire state of Florida on nursing homes, who's formed a new advocacy group, Families for Better Care, and has been pushing for greater transparency and oversight. From the National Council of Gray Panthers, a resolution concerning these same matters. The Consortium for Citizens with Disabilities, realizing that our nursing homes are also residents for many individuals with disabilities, though the coalition is working vigorously to provide community-based alternatives. And then from AFSCME, which calls for legislative action on Jan Schakowsky's bill. These are just a few examples of the great interest in our topic today. And of course, as usual, we invite comments over the next 2 weeks, any other written statements that any individuals or groups may want to make a part of our record. I would welcome our panel. We're thankful for them joining us today. First, I would like to welcome Dilly Satterwhite from Austin, who will be sharing her brother Stephen Morales' story. Then Melinda Haschik will come next from Southport, Connecticut, on the edge of Mr. Larson's district. She is fortunate to have recently recovered from COVID-19, but can identify some of the obstacles that she and her colleagues have faced. We're pleased to have Nicole Howell from Mr. Thompson's district out in California. She is an ombudsman who has advocated on behalf of long-term care residents. Then we'll hear from Toby Edelman, the senior policy attorney at the Center for Medicare Advocacy. She's a well-known advocate with expertise in the regulation of nursing homes and our failing survey and enforcement system. After that, we'll hear from Dr. David Grabowski, who's a professor at Harvard Medical School and a national expert on nursing home policy. He was recently appointed also to serve on the Independent Coronavirus Commission for Safety and Quality in Nursing Homes. Then from Arizona, Dana Kennedy, who is the state director of AARP, representing 890,000 Arizonans. She's had years of experience working on long-term care issues. And finally, the committee will hear from Rebecca Gold, the president and chief executive officer of a hospital located in Mr. Reed's district, upstate New York. She'll provide us some firsthand experience concerning how she's navigated the crisis. And I'll ask Mr. Reed if you want to add further introductory comments from your work with Ms. Gold.
Thank you, Mr. Chairman. And I do want to welcome, and it's my privilege to introduce Becky Gould to the Ways and Means Committee here today. And she is the president and chief financial officer of Schuyler Hospital, which is located in Watkins Glen, New York, in our district. And she's had years serving in that capacity and working with this population that we're discussing here today. The Schuyler Hospital is a critical access hospital with a skilled nursing facility attached. So Becky not only runs the place, she walks the rounds, knows those patients. And Becky, we welcome you to this committee, and your firsthand experience and input is greatly appreciated by, I believe, all the members on this committee today. So thank you, Mr. Chairman, for that opportunity.
Thank you, Mr. Reed. Each of the statements of our witnesses will be made a part of the record in its entirety. I would ask you to try to summarize your testimony in 5 minutes or less for you and for our colleagues as they ask questions. I'll do a little gentle tap with my gavel here as time is reached and ask you to try to conclude your remarks at that point. To help you with the time, you can keep an eye on the clock that should already be pinned on your screen. I would then call on Ms. Satterwhite. It's good to have a fellow Texan here. And of course, additional condolences for the devastating loss of your brother. And I appreciate your participating to share that story. Ms. Satterwhite?
Thank you, Chairman Doggett, Ranking Member Nunes, and the members of the committee for having me today. My name is Delia Satterwhite. I live in Austin, Texas, and my brother Stephen Morales passed away on April the 16th, 2020 from COVID-19 that he contracted while residing at Riverside Nursing and Rehabilitation Center here in Austin. My brother had dementia, and in July 2016, he went to Riverside Nursing Home to live. I would go and visit with him on weekends and sometimes would pop in to check on him during the week on my way home from work. I would usually spend Saturdays with him, bringing some of his favorite foods like tacos or menudo from Joe's Bakery. When the nursing homes went on lockdown on March the 13th, 2020, I had seen my brother just the week before the lockdown. He was in good spirits, and I had told him that I would be returning the next Saturday with my son so he could get his hair cut and trim his beard. That never happened. The day before my visit, I was called and told that they were going to lock the facility down and no workers and no visitors were allowed. I asked if I could drop off the snacks I had already bought, but they did not want to risk bringing the virus in. I understood that and wanted them to keep my brother safe. I would visit sometimes and talk to my brother through the window, but it was hard knowing he couldn't have his family with him. After the lockdown, it was hard to reach any of the staff at Riverside. They did not want to take my phone calls, and would put me on hold for so long that my lunch break would be over before I could ask how my brother was doing. I would call almost every day, usually 2 or 3 times a day. No one wanted to talk to me. It felt like they were keeping a secret. No one wanted me to know what was happening. They didn't want me to know the virus was there. I was eventually contacted on April the 3rd, 2020, that my brother was being isolated because he was running a fever and coughing. He tested positive for COVID-19 the following week and then developed pneumonia. I requested that he be sent to the hospital to receive the medical care that he needed. The nursing home refused, and he passed away in his room on April the 16th. The worst part is knowing that he died alone. I wanted to be there. His family loved him and should have been with him. When I went to pick up his belongings, they gave me a box of things for a woman who had the same last name, Morales. It was disrespectful to the life of my brother. He was a good man and his life mattered. It took a week for Riverside to find my brother's belongings and return them to me. This nursing home did not provide the care that my brother deserved. They refused to provide information about other COVID-19 cases and deaths, and did not want to test the residents and staff. They never sent him to the hospital, even after I requested he be sent. When they closed the nursing home, they said they wanted to keep the virus out, but they didn't make a plan to make sure workers didn't bring it in. My brother wasn't leaving the nursing home. The virus was brought into him. The workers were still going home and could get the virus anywhere. I don't blame the workers. They were doing their job. They should have been given the PPE they needed to keep them and their patients safe. And if someone was sick, they should have been given leave to stay home. The nursing homes also need to be testing everyone all the time. Someone can test negative today, but have a positive test next week. If we were testing and providing PPE, the virus wouldn't have gotten to my brother. My brother should still be alive. I will continue to share his story so other families don't have to go through this. I still check in with some of the families of other residents at Riverside. I want to make sure their loved ones are being taken care of. Thank you for allowing me to share Stephen's story today and for this important hearing so we can all learn the truth about what is happening in these nursing homes.
You reflect the kind of pain that has afflicted families all over the country, and we do extend our sincere condolences. Ms. Hashik, can you enlighten us on the experience of staff at nursing homes?
Good evening, good afternoon, Chairman Doggett, ranking members Nunez, and members of this committee. Thank you for allowing me to share my story today. My name is Melinda Hashek. I'm a nursing home worker from Stamford, Connecticut. I've worked in healthcare industry for over 20 years. Through working to take care of my residents is rewarding. My workplace can often be stressful and difficult. Just in the last 3 years, my facility has 5 different administrators with different sets of policies. It made our lives hectic. Some of my coworkers and I decided enough was enough. We voted to unionize last year, are still fighting for our first contract. Some of the things we had asked for were time and a half, family sustaining wages to help short staffing, and a training fund. The pandemic has only deepened the need for what we are fighting for and made the problems that are existed worse. My facility was hit hard by PPE shortage. We were in short supply. We were being told to use single-use gowns and masks. Just recently, the corporation that owns the facility where I work was fined for washing single-use suits instead of replacing them with new ones at another facility nearby. It was so bad that I had to find PPE for myself and my coworkers using own money and the help of family and friends. I couldn't bear to risk exposure to COVID-19 so recklessly. Once we started hearing of cases of COVID-19, our facility was still figuring out internal policies and best practices. While we did make an effort to quarantine our residents with COVID-19, we were so short-staffed that staff worked both in quarantine and unquarantined areas. What was worse that we weren't always told who tested positive either, and though the information was known to parts of management, since my work involves being hands-on with residents, including being available for CPR during emergency situations, I unknowingly work with residents that tested positive for COVID-19. Even with gown and surgical masks, I didn't have full protections like goggles for my eyes. This is how I believed I contacted COVID-19. I am a single mother and I live in a home with my two teenage daughters and my sister. After I tested positive, I had to stay in complete isolation from them. I couldn't afford to get my kids sick, especially with one of them, my daughters who has asthma. This meant I couldn't give my children any affection, any hugs, or any kisses when it was time to eat. I ate alone. My daughters had to figure out how to cook for themselves. It was so hard not being able to support them. I could not touch my kids until my birthday. Between self isolation when my sister was ill and then contracting COVID-19 myself, I was out of work for almost a month. I had to use all my sick days, vacation, and personal days in order to continue to receive pay. Now I can't afford to get sick because that would mean I couldn't provide for my family. As a worker who cares for vulnerable people and my risk of health to do it, I shouldn't have to be in this situation. The whole process took a huge mental toll on me. There were many days I came home crying. Today we are still understaffed, overworked, and still do not have enough PPE. While I appreciate the donations of food and the occasional pizza party we receive, my coworkers and I do not need a pizza party. We need PPE. Even after Even after my coworkers and I continue to contract COVID-19, communication is still a problem we face. We still don't know which residents are infected. Even though there are clean zones and a COVID-19 wing, we fear that the potential exposure because of lack of information and protocols keep changing. That's why our initial contract fight for family sustaining wages, tuition reimbursement, funding, and training and sufficient equipment is more important than ever. I love working with my residents because oftentimes I know it's the only family they have. So not only do I owe it to them, but I owe it to my own family and myself and to hold these families accountable. Thank you for your time.
I call on the head of the meeting. Thank you very much for your testimony and your service. Ms. Howell?
Yes. Chairman Doggett and Ranking Member Nunez, thank you for inviting me to testify before you and this distinguished subcommittee. My goal today is to help you understand the landscape of long-term care and how COVID-19 exploited its weaknesses and left residents without protection or oversight. I pray that my words are enough to help you understand the plight of 1.7 million seniors and disabled adults in the United States who live in skilled nursing facilities. I lead a team of staff and volunteers that are charged with resolving issues for residents living in licensed long-term care facilities. We are often the only place for residents and families to turn when they need advice, guidance, and assistance resolving serious issues such as bed sores, isolation, eviction, discharges, as well as intervening in instances of abuse and neglect. COVID-19 is an opportunistic disease that continues to prey on our most vulnerable citizens and exploits the foundational weaknesses within a web of regulatory and safety net services. In the United States, long-term care is paid for in two primary ways, sometimes with income and savings or long-term care insurance, but oftentimes more likely with government dollars. Assisted living costs at least $5,000 per month, pricing many out of access and leaving our most vulnerable hardworking adults reliant on the Medicaid system as they age. These residents are often in stark contrast to Medicare patients who are only at skilled nursing facilities for a short stay following hospitalization and require therapy and care, along with a healthy dose of visits from concerned family and friends. Medicare patients receive the lion's share of attention and draw in a reimbursement rate in excess of $600 per day, whereas recipients of Medicaid are billed at less than $200 per day, the lowest payer source for skilled nursing properties. Even the layperson can see the strong disparity in payment and understand the perverse incentive for skilled nursing providers to seek out short-term Medicare patients versus long-term Medicaid residents. A particularly callous administrator remarked recently that they could make more running a doggy daycare than they can with a Medicaid resident. For those individuals who are able to pay in excess of $5,000 per month for care, they are more likely to choose what is referred to as assisted living. That does not provide medical care, but those residents who are able to pay often have the same levels of impairment as those who live in skilled nursing facilities. It's important to note that skilled nursing facilities that have significant number of African American and Latino residents, irrespective of facility size, rating, or location, are twice as likely to have coronavirus infections as those facilities whose residents are white. The New York Times reported that more than 60% of nursing homes, where at least a quarter of the residents are Black or Latino, have reported at least one coronavirus case. That is double the rate of facilities where Black and Latino people make up less than 5% of the population. Today's skilled nursing residents are a mix of individuals who experience dementia, physical impairments, mental health issues, and homelessness. They live together in aging buildings without appropriate isolation capabilities and often under the management of companies unable to adapt to the rapidly changing care conditions created by this pandemic. The issues that COVID-19 exploited are not highly technical or complex. They are basic issues of training and adequate staffing. California facilities with one or more patient with a COVID-19 case had, on average, 25% fewer registered nurses per resident. In addition, 91% of nursing homes reported at least one case of COVID-19 had a prior violation related to infection control prior to the pandemic. These violations are not egregious or significant. They are failures to ensure basic hand washing or wearing of protective clothing. Now, poor staffing in long-term care facilities was the gasoline to COVID-19's match. Within the long-term care industry, direct care workers, on average, earn only $1 to $2 more per hour over state minimum wage, forcing these dedicated people to work 60 to 80 hours per week at multiple locations to pay the most modest of rent and expenses. Meaning, you can have a caregiver that works at one facility where there are active COVID-19 infections, yet is forced to work at a second location and may transmit the virus to residents. Now, facilities did not cause this disaster, but in some instances, their response has been substandard, and they did it with the people's money. A skilled nursing facility can choose to be private pay, and some do, but largely they do not because the lucrative and reliable stream of Medicare dollars is highly attractive. In exchange, they care for a few Medicaid residents along the way, but they will take often the first opportunity to discharge that resident. Sadly, some facilities have exploited this pandemic and the lack of oversight to evict residents without notice, sending them to homeless shelters that cannot provide proper care. This is not a new practice, but with facilities locked down, it is difficult for ombudsmen like me to assure proper accountability and intervene on behalf of residents. This crisis is the direct result of poorly applied resources, inadequate staffing, and loosely imposed regulations that fail to protect these precious lives. In order to address these critical issues, I respectfully request that you consider the entirety of the recommendations I have made to you today in writing. Thank you.
Thank you for your testimony and for those recommendations. Ms. Edelman?
Thank you, Chairman Doggett, Ranking Member Nunes, and members of the subcommittee. My name is Toby Edelman. I am a senior policy attorney at the Center for Medicare Advocacy, a nonpartisan, nonprofit, public interest law organization that works to ensure fair access to Medicare and high-quality care. I have advocated for residents at the national level for more than 40 years. I want to acknowledge the deaths of more than 50,000 residents and staff from COVID-19. We grieve for residents, staff, and families. The past several months have brought to fuller public awareness the deadly consequences of poor care, inadequate staffing levels, and lax infection control practices. Although these problems have been identified for decades, they have been made worse by recent deregulatory actions. The Trump administration has weakened and dismantled the regulations and guidance developed over the past 30 years to implement the 1987 Nursing Home Reform Law. During the pandemic, the administration unilaterally decimated long-standing statutory protections for residents and suspended inspections and enforcement for all but the most serious violations. It could not have implemented such drastic changes on its own.
I can't hear.
The law has, the reform law, excuse me. Can you hear me now? Is this okay?
We can't hear you now.
Okay,
Thank you very
I'm
much.
sorry, sir.
We
Okay,
missed about 30 seconds of you.
okay. The reform law governs nursing facilities that voluntarily choose to receive reimbursement from Medicare and Medicaid, and that means nearly every facility in the country. The law has three fundamental parts. First, the standards of care that facilities must meet to receive federal reimbursement. Second, the survey process. Typically, state health departments conduct unannounced annual and complaint visits called surveys to determine whether facilities meet federal standards of care. Third, the enforcement system, which authorizes a range of penalties for violations of standards. My written testimony describes changes by the administration before and since the pandemic. Here's a sample. In 2017, the administration explicitly rescinded and replaced 2 Obama guidance documents, essentially gutting enforcement and making it even less likely that there would be any penalties. CMS explicitly shifted the types of fines from per day to per instance. In 2016, a typical per day fine averaged more than $60,000. In 2019, the now more typical per instance fine was less than $10,000, too often just the cost of doing business. Although the administration has less authority to make unilateral changes to care standards and the survey process, it repeatedly asked nursing homes what they wanted and clearly signaled its intention to accommodate them. It delayed enforcing new requirements, limiting dangerous antipsychotic drugs, and requiring facilities to develop care plans as soon as residents were admitted, not weeks later. It proposed allowing facilities to use pre-dispute arbitration provisions in admissions contracts. Last July, CMS proposed watering down other care standards, including eliminating the requirement that a facility's infection prevention specialist be on site at least part-time. The proposals use the word burden or burdensome more than 100 times in 32 pages. The administration proposed surveying facilities as infrequently as every 3 years. Since the pandemic, the administration has unilaterally suspended parts of federal law entirely. In March, CMS banned all visitors, including families and ombudsmen, the program designed to advocate for residents. CMS waived transfer and discharge rules under certain circumstances. CMS waived the requirement that facilities use only nurse aides who complete at least a 75-hour training program. Facilities are now hiring people with as little as 8 hours of training. CMS waived, possibly permanently, requirements that facilities submit data about nurse staffing levels and resident assessments. And finally, CMS suspended all standard and complaint surveys and suspended enforcement for all violations except those classified as immediate jeopardy, less than 1%. CMS must reinstate federal protections for residents and comprehensive surveys and enforcement immediately. For the longer term, 4 changes are essential. First, all facilities must have sufficient numbers of well-trained, well-supervised, and well-compensated nursing staff. All facilities need RNs around the clock. Second, the survey and enforcement systems need to be strengthened, and enforcement needs to be implemented on a corporate-wide basis. Third, states and CMS must establish and enforce meaningful standards for who is eligible to operate a facility and receive federal reimbursement. Finally, we must require that facilities spend a reasonable proportion of the billions of dollars they receive each year on care for residents. The coronavirus pandemic has made all too visible the lethal consequences of poor care and no oversight. We can and must learn from what has gone wrong and do better in the future. Thank you.
Thank you very much. Dr. Grabowski?
Thank you. Chairman Doggett, Ranking Member Nunez, and distinguished members of the House Ways and Means Health Subcommittee. Thank you for convening this important conversation to examine the COVID-19 nursing home crisis. Nursing homes have been ground zero for COVID. Over 50,000 Americans have died in nursing homes, and many of us think the true number may be much higher. Just 0.5% of the entire population represents nearly half of our country's COVID fatalities. We lost over 1 in 10 nursing home residents in New Jersey nursing homes alone. Think about that, over 1 in 10. Efforts to stem this plague are also taking a huge toll. Nursing homes are in all-out lockdown because visitors are not allowed. Family members like Ms. Satterwhite have been unable to see their loved ones since March. Staff are frightened given the lack of COVID testing and PPE. And for good reason. New federal COVID data suggests over 500 staff nationally have died from COVID, making nursing home caregiver the most dangerous job right now in America, with a higher death rate than logging workers and commercial fishermen. Facilities are experiencing severe staff shortages as many individuals are unable or unwilling to work in these conditions. We hear a lot about the heroes working in hospitals, But these individuals working in nursing homes, many of whom are making close to minimum wage and risking their health, are heroes too. Nursing homes have been underfunded for many years and struggled with staffing and other issues prior to COVID. In many respects, COVID is, to quote a colleague, a crisis on top of a crisis. So what do we do about all of this? Well, first, we need to determine why COVID has entered certain nursing homes and not others. Some are suggesting COVID is just a bad apples problem and are quick to point fingers at ineffective state policies or poor nursing home practices. This is not what my research or the independent research of other academics suggest. Indeed, 3 of us published a Washington Post op-ed on exactly this issue earlier today. We find that cases are concentrated wherever COVID is present in the community. The secret weapon behind COVID is that it spreads in the absence of any symptoms. Visitors have not been allowed in most facilities since March, but staff unknowingly bring the virus from the community into the facility. As a result, if COVID is in the community where staff live, COVID is soon to be in the nursing home where they work. This suggests COVID is not just a bad apples problem, but rather a system-wide problem that can impact any nursing home in any state. This is a time to support all our nursing homes. So what should we do? Staff and residents are in desperate need of COVID testing. Until we get rapid and accurate testing for all staff and residents, we won't be able to contain COVID. And this can't just be a one-off. We need a surveillance program that regularly tests staff and residents in order to identify new cases as they emerge. The virus also spreads because staff lack PPE, just as Ms. Haschak described earlier. There's a huge shortage of masks, goggles, gloves, and gowns that has led to staff reusing these supplies or simply going without. Rather than pushing the logistics and costs of testing and PPE to states and nursing homes, the federal government needs to take ownership of this issue. The federal government should set a consistent policy across all U.S. nursing homes and then provide states and nursing homes with the resources to achieve it. And if we have testing and PPE in place, we would be able to move safely towards opening nursing homes again to family members. Another issue is supporting and growing the direct care workforce. Nursing homes need higher reimbursement for COVID cases to prevent layoffs and maintain staffing levels. Staff also deserve a wage that is commensurate with the risks they are taking. The federal government needs to put dollars in place that directly flow to workers in terms of hazard pay and other benefits. I want to conclude with a simple statement. It didn't have to be this way. Much of the negative impact of COVID in nursing homes could have been avoided. However, rather than prioritizing the safety of the 1.3 million individuals that live in nursing homes and the staff that care for them, we failed to invest in testing, PPE, and the workforce. We allowed a problem that could have been contained to now grow into a national crisis. Now that we are here, it is time for the federal government to make the necessary investment to mitigate the spread of COVID across all U.S. nursing homes. We owe that to our parents and our grandparents and the individuals that care for them. Thank you.
Ms. Kennedy?
Thank you, Chairman Doggett, Ranking Member Nunes, and members of the subcommittee. My name is Dana Marie Kennedy, and I'm the State Director for AARP Arizona. On behalf of our 38 million members and all older Americans nationwide, AARP appreciates the opportunity to testify. We are calling on Congress and the administration to take immediate action to stem the continued loss of life and improve conditions in long-term care facilities. You've heard the high number of nursing home and other long-term care facility deaths and the share of the overall COVID-19 deaths. In Arizona, 65% of deaths in Maricopa County are from people who lived in long-term care facilities. These were moms and dads, grandmas, grandpas, uncles, and aunts. AARP has heard from thousands of families across the country. Here's just one story from an Arizona family. Norma moved to a nursing home after having a stroke. Her son Damon visited his mom regularly. In March, he thought his mom looked tired and a little sick. He reported the symptoms and 3 days later was denied access to the facility. For more than a month, he tried to see his mom or call the facility, but mostly got voicemail. Norma's family only learned that she was gravely ill when the hospital called. Unbeknownst to them, she had been transferred and put on a ventilator. The hospital asked permission to pull the cord. Norma's son denied the request. She died a week and a half later. AARP urges action on a 5-point plan to slow the spread and save lives. 1, care facilities must have the PPE and testing they need to identify residents and staff cases. In Arizona, assisted living facilities still report they don't have adequate PPE. This is 15 weeks after not allowing families to visit, and this is unacceptable. Testing is also not available or happening in many nursing homes and long-term care facilities. In Arizona, skilled nursing facilities have done 1 round of tests of staff and residents and do not plan to do any more preventative testing. Assisted living facilities have yet to even do 1 round of testing. This is outrageous. The only way to truly protect residents and staff health and safety is to have regular testing in accordance with the CDC guidelines. 2, there must be adequate staffing to provide necessary care, and long-term care ombudsman must be allowed to visit residents in person. Many of these facilities struggled with staffing issues before the pandemic. In addition, ombudsmen play an important role advocating for residents and their families, but in many places are currently unable to conduct in-person visits. We urge this restriction to be lifted. 3, care facilities must report publicly on a daily basis if they have confirmed COVID-19 cases. Residents and family need information, the community needs information, and when there are discharges or transfers. AARP has long called for increased transparency of COVID-19 cases in long-term care facilities, and we appreciate CMS action that takes steps towards more transparency. However, more must be done. Reporting is still not happening consistently, and reporting generally does not include demographic data. We need oversight, accountability as billions of taxpayer dollars are distributed to nursing homes. We urge Congress to establish guardrails and transparency to ensure such funds are used for testing, PPE, staffing, virtual visitation, and other items that directly relate to resident care, well-being, prevention, and treatment. 4, virtual visitation must be made available and facilitated regularly between residents and their families. Congress must require virtual visitation using readily available technology like we're using right now. We also urge Congress to provide funding for technology, equipment, and support for virtual visits. That's why AARP supports the Bipartisan Access Act. 5, proposals to grant blanket immunity related to COVID-19 for long-term care facilities must be rejected. The pandemic has put residents' health, safety, and quality of care at unprecedented risk. We know that staff in many long-term care facilities are doing heroic work, putting their health on the line for others. But sadly, many families who have contacted us have loved ones who were not treated with the compassion or dignity they deserve. AARP strongly urges Congress to protect the safety of residents, including by maintaining their rights of residents and their families to seek legal redress, to hold facilities accountable when residents are harmed, neglected, or abused. Litigation is an option of last resort. At this time of limited oversight and accountability and horrific death tolls, Congress should not strip away the rights and protections of residents. Families nationwide are looking to Congress and the administration for swift action to protect the health and safety of their loved ones in long-term care facilities. Thank you, and I'm happy to answer any questions.
Thank you so much. Ms. Gold?
Thank you for allowing me to come today and share our unique perspective. We are a 25-bed critical access hospital that also has a 120-bed skilled nursing facility attached. So we're a little bit different situation than some of the stories that you've heard here today. And actually our situation is a little different being in New York too than some of the things that I've heard here today. But I did want to let you know about the hardships that we're facing here. So being in a nursing home administrating position, the changing regulations have been difficult for us to keep up with. The regulations have been changing constantly, and with a limited number of staff and resources to be able to implement those changes, it is difficult to comply with them. The penalties for noncompliance in New York State equal a misdemeanor or a loss of your operating certificate, or for a nursing home administrator, that misdemeanor would mean loss of your ability, your career, basically, in the future. And so the other thing that happened here on March 25th, 2020, Governor Cuomo and the New York State Department of Health issued an executive order that prohibited nursing homes from denying patients admission or readmission to a nursing home based on the confirmed COVID positive diagnosis. We were very thankful and lucky here to be part of a health system. We're a part of Cuga Health System. We partner with Cuga Medical Center, and we knew from the beginning that that could have a devastating impact on our nursing home. And so we worked together in order to ensure that we actually would never admit a COVID-19 patient into our nursing home. And I think that this is something that actually could be regionalized in New York State and possibly other states as well. So we worked together to ensure that any COVID-19 patient that was positive that came to our facility was actually transferred to Cuga Medical Center. If they were going to be admitted to the nursing home, we kept them in a swing bed stay until we could confirm that they were not positive COVID patients, so that they would not be injected into our nursing home. And I'm happy to say that as of today, we have not had a positive COVID case in our nursing home. Another issue that we face that's been talked about already here is staffing. So even prior to COVID-19, we had a nationwide shortage of registered nurses as well as CNAs. Pay is part of the reason that we talk about that. But that we've had to reassign those critical resources that we have to other duties. So RNs have been reassigned to swab staff. CNAs have been reassigned to man tables and screen people as they come into our facility. This does leave our residents with less face-to-face time with the caregivers that provide the services for them, and could lead to quality issues in other nursing homes where staffing levels are not as adequate as ours are. Resident quality of life is another issue that has been faced here. And although we do understand the need for the measures that have been put in place, such as swabbing staff on a weekly basis, we would respectfully request that perhaps metrics be developed to allow visitation in some nursing homes, such as our county, where we have only had 14 cases of COVID to date, and do not have any active cases in our county today, because this puts the no socialization rules that have been put in place by executive order here are causing our residents to face anxiety and depression. I round in the nursing home regularly, and I had one of the residents grab my arm and say to me, "Can this last forever? Can I really not see my family again?" These people are just distraught. And so we need to work together to find a way to work with administration and the Department of Health to figure out how we can allow safe visits in our nursing homes. Reimbursement is the last issue that I wanted to talk about here. I am happy that we do have staff testing in our facility and that we are being able to detect people that have COVID in our hospital. But there is a cost and a price tag that comes along with that. So for us, it is $100 for the processing of each COVID test that we send to be processed. That does not include the PPE cost. That does not include the courier cost. That is costing our facility $28,500 a week. That is $114,000 a month. Or if you did this for a full year, that would be $1.4 million. Nursing homes run on very thin margins, which is why we have such staffing needs, because we can't afford to pay somebody like our competitor, like Target does. So it's hard to retain those staff providing such an important service, but it's also hard. It's not easy work. And so we do need fair wages for those people. And in order to do that, we need to see increases in the rates that we receive. We have received, I do want to be fair, we have received some PPE testing, PPE and limited testing supplies from our state, but we have received no funding directly for the testing regulation that has been imposed upon us. So I do want to reiterate that we are lucky that we have not faced some of the challenges that others have talked about here today. And we do want to provide a safe, caring environment, and we do want to comply with the regulations that have been put upon us. But I did want you to understand some of the other challenges that we do face in our roles in caring for the vulnerable population directly. Thank you for your time.
Thank you for your insightful testimony. Without objection, each member will be recognized now for 5 minutes to question our witnesses. We'll do it in seniority, switching back and forth between majority and minority members. Members are reminded to unmute yourself when you're recognized for your 5 minutes, and particularly important to direct your question to a specific witness so that witness can unmute and respond. I will begin by recognizing myself and direct my first questions to Dr. Grabowski. Doctor, would you describe what the effect has been of having a fragmented approach where the Trump administration really relinquished its responsibilities and told the governors to go out and compete to get the PPE that they needed?
Yeah, it's been a little bit like a game of hot potato. The federal government took that responsibility and pushed it out to the states. The states then in turn pushed it to the nursing homes. No one has really owned this issue. The federal government, to their credit, did say we would provide 2 weeks of personal protective equipment to every nursing home in the country. However, as was already stated, many nursing homes are still waiting on that PPE, and many other nursing homes have received PPE that isn't even usable. So I would say that the federal government has not taken care of this issue around personal protective equipment. We should nationalize the supply chain. We should make PPE available to all U.S. nursing homes.
Thank you. It's my understanding that CMS has created an oversight commission, and that their version of oversight was to hire a contractor, which may want to do continued business with CMS, to select that commission. Is that correct?
As you said when you introduced me, I'm on that CMS commission, and they did hire. And I should note that I'm speaking for myself today, not for that.
Of course. And that commission, I understand, has had its first meeting. Have those meetings been open, like our meeting today, or have they been closed?
Our first meeting was closed.
And has there been any indication that the commission will be open to the public?
There hasn't been any indication that the meetings will be public.
Well, I'm very pleased you're on it. I think you have important viewpoint to convey, but I just looking for any reason why CMS would be unwilling to participate today, other than an unwillingness to defend its sorry record. There was a suggestion that they have their own oversight commission, but I can see that while that commission may make a contribution, it's not the kind of public airing of concerns that we really need. And some of that, the best of that public airing has come from investigative journalism. Without objection, I will make a part of our record the New York Times article about the removal and eviction of Medicaid residents from nursing homes, as well as a separate article concerning some of the problems with PPE and other staffing issues in Austin by Margaret Nicholas of the Austin Chronicle. And Ms. Howell, I'd like to ask you a little more about that. I must say that I've tried to follow activities in nursing homes for years. I was shocked to read that people are being evicted from nursing homes and placed in homeless shelters. As if we didn't have a big enough homeless problem, but people that would be placed there without anyone to help them with their medications and with surroundings that may be unsafe for them. Have you seen this yourself and heard about this in California?
Thank you, sir. Yes, this is a long-standing practice where facilities who have potentially residents they've had for a long period of time that are homeless, that they feel they no longer care for, they will attempt to discharge them to alternative care settings, homeless shelters being one of them. This has been a long-standing practice, which is why it was so important that Ombudsmen were receiving the notifications related to discharges along with the resident and or their responsible party in a language they understood. However, that is not happening. It was exacerbated in places like California, where we have a program to get individuals who are homeless into hotels. And I saw skilled nursing facilities exploiting that Project Room Keep program and using it to discharge residents they did not want, hoping that no one would notice.
And there is a requirement that they notify the ombudsman when this happens, but you've seen that not occur.
We've seen that not occur, but it also changed. As Ms. Gould said, there's been a drastic reduction in regulations ever changing that is very challenging to keep up with. And I think in an attempt to try and sort of prevent hospital impaction, skilled nursing facilities, some regulations were waived, that being one of them. And that is one that needs to be reinstated immediately. Between March, April, and May, the discharge notices we received reduced by 50%. Going from approximately 6,500 to 3,000. That is a significant reduction, and I believe it indicates that there are residents being discharged to inappropriate care settings.
And during that period of time, have you had any means of communicating with people within your jurisdiction as ombudsman?
Yes, my team members are particularly ingenious. We have used phone, we have used Zoom, we use Google Hangouts, we use FaceTime. For those residents who are able to connect that way, it is useful. but we know that there are so many who are not. And like the family member stated earlier, it has been many months without any contact. This has significant harm for residents, and I think actually aids in their decline.
So not having them there has an impact just in terms of social contact with a loved one, but does it also have an effect on the quality of care that they are likely receiving in some of our nursing homes?
Absolutely. Not only do family members aid in care and know their individual and help provide assistance, but they also are on the lookout. And without eyes and ears in the facility, no one knows what is happening. And while I believe many facilities are doing their best, I think there are some that may be using this time and not providing the best of care, and residents are unable to speak for themselves.
Thank you very much. Ms. Kennedy, why not grant these nursing homes immunity? I understand this has been a top priority of Mitch McConnell and some of the people in the Senate to grant everybody immunity.
Well, granting blanket immunity to nursing homes is just wrong. It stops residents from holding long-term care facilities accountable for harm caused by substandard and dangerous care, including care that results in a resident's death. And many nursing facilities had safety violations before the pandemic. And according to a recent study from Government Accountability Office, 8 out of 10 nursing homes were given citations for not following even basic infection control practices. So many facilities were not staffed adequately before this pandemic, leading to devastating falls, pressure ulcers, and worse.
Thank you. Lastly, Ms. Edelman, you have made reference in your testimony to the possibility of establishing a medical loss ratio for nursing homes. How would that work and what benefit would it have?
Thank you, Congressman.
Oh, I think we've lost you again, Ms. Edelman.
I'm sorry.
There you are.
This is a very important issue to make sure that facilities actually spend a designated portion of the reimbursement that they receive from Medicare and Medicaid on actual care for residents. There isn't any obligation now that they spend the money on care, even though that's what the expectation is. So we do have experience with this kind of requirement. The Affordable Care Act said that Medicare managed care plans must spend a designated portion of their money on care for their plan participants. We think that would also be very useful in nursing homes.
Okay, thank you. Thank you very much. Mr. Nunes.
Thank you, Mr. Chairman. I want to yield my time to Mr. Reed, who's been really laser focused on this issue, doing a lot for the state of New York. So I want to yield my time to him, if that's okay.
Surely.
Well, I thank Mr. Nunes for yielding his time to me, and thank you, Chairman, for convening this committee hearing today. And as indicated, this has been a priority of our office since the beginning of this crisis, the nursing home situation. And I will just tell you, what we really need to be focusing on today is that there needs to be accountability and leadership and action for the past mistakes that happened during the course of the pandemic crisis. But most importantly, that as we move forward, we must protect the loss of life from occurring in the future, like we've seen in particular in New York State. Since this virus first hit our shores, we have known our nation's parents and grandparents were particularly at risk. While many states, 45 in fact, Mr. Chairman, chose to follow CDC guidance, CMS guidance regarding nursing home regulations, a small group of governors made fatal errors that directly exposed the elderly to COVID-19 and placed our most vulnerable population in harm's way. Governor Andrew Cuomo in my home state of New York enacted a series of disastrous policies that directly led to the deaths of thousands of our state's parents and grandparents. We know this virus is not going away anytime soon. If we are to ensure our nation's parents and grandparents are protected moving forward, we need to fully understand why Governor Cuomo and the 4 other governors ordered COVID-19 positive seniors to be forced into nursing homes, exposing the entire nursing home population and staff to death. Mr. Chairman, I'm asking, this is a copy of the March 25th executive order from Governor Cuomo, which I ask unanimous consent be included in the record. Thank you. I assume that's a yes, because I didn't hear you, Mr. Chairman. It was muted, but thank you. I find
Sure.
it particularly,
It's without objection.
thank you. I find it particularly important to submit this for the record because as you indicated in your opening remarks, Chairman, transparency is important. And this order has been deleted from the public records on the internet for the state of New York. And I want to also note, Mr. Chairman, immediately after Governor Cuomo imposed this order to force COVID-19 positive patients into nursing homes, the Society for Post-Acute and Long-Term Care sent a direct written letter warning to the governor, and it stated, and I quote, "The mandate was overreaching, not consistent with science, and beyond all, not in the least consistent with patient safety principles," and particularly indicated that the order caused significant risk of fatality to nursing home patients. So I would also like to seek unanimous consent to enter into the record the March 26th, the day after the March 25th executive order letter of the society.
Without objection.
Thank you, Mr. Chairman. Instead of working together with us, the medical community, and advocates on solutions, Governor Cuomo is focusing on lying to the American public as evidenced by independent fact checkers who ruled the governor did not follow federal guidelines, even though he said it was the fault of the Trump administration. Even now, he continues to refuse to take responsibility for the state's errors. It is offensive to those who have lost a parent or a grandparent and who just want answers like myself. Our investigation in this committee should serve as the foundation of future nursing home policies and decision-making. The result should be a comprehensive strategy, Mr. Chairman, to keep our nation's parents and grandparents safe from what I fear will be a return to a crisis level of nursing home deaths in the fall as the virus potentially reemerges. Congress must ensure that state leaders follow the proper best practices tailored to meet the specific needs of the community moving forward. We should be fighting for people like Donna, who reached out from our district to our office, who recently shared her story with us after failing to hear from a single New York official in response to her plea for help. She is extremely concerned about her dear Aunt Rita, who has been isolated and unable to interact with her family for months. And as Donna said, I'm pleading with you to address this. We cannot have a one-size-fits-all approach. We need someone who cares enough to speak up for those who can't. We should also stand with Doreen from our district, who has been unable to see her 95-year-old mother for weeks and has described the whole situation as a nightmare for the family. The American people need our help, and they are relying on us to act because they have lost faith in their state's competence and ability to roll up their sleeves and put a plan of action in place. And I join with the witnesses here today that say we owe it to our parents and grandparents to do better. But most importantly, we shall not cast blame. We should demand justice, accountability, and take action that makes sure that tens of thousands of seniors do not face the death sentence that they faced in New York State in regards to the March 25th order, sending COVID-19 positive seniors into nursing homes without any scientific or data to support such an egregious policy decision during the course of this pandemic. And with
Thank you,
that,
Mr. Green. Thank you very much, Mr. Thompson.
Thank you, Mr. Chairman, and thank you to our excellent witnesses that are with us today. And my condolences to Mrs. Satterwhite for the loss of her brother. And I want to thank in particular Nicole Howell, whose work in my district in Contra Costa County has been incredibly important. Thank you for all that you and your team are doing. This is an important hearing. It's a tragic one, Mr. Chairman, but it's an important one. COVID-19 has ravaged every part of our society, but nowhere has it hit harder than in our nursing homes. And it's been exacerbated, as pointed out by Mr. Grabowski, Ms. Kennedy, and Ms. Gold, by the fact that family members aren't allowed to visit their loved ones. And they are themselves ombudsmen for this industry and for the patients who are there. I have a woman in my district who quit a very lucrative job and took a job in a skilled nursing facility so she could be close to her parents, to be able to watch over them. So this is really an important issue. As Ms. Howell knows, Contra Costa County had 18 deaths last week. 16 of them were in nursing homes. In my conversations with local public health officials and nursing home operators themselves, a few things have become clear. First, there's still not enough PPEs. Second, once COVID appears in a nursing home, it's basically impossible to stop. And third, wages for nursing home employees are way too low. Fourth, the measures required to contain and mitigate COVID in nursing homes are too expensive for many nursing homes to implement. They need our help. I'd like to ask Ms. Howell a question. You recommended in your testimony that nursing homes and long-term care facilities increase wages for employees. In my district and other places.
Will you tell them?
I can't hear.
Can you hear?
No, I'm sorry, you cut out for a second.
Okay. The low wages has exacerbated the problem because employees have to work in 2 or 3 different places. And they, 2 or 3 different skilled nursing facilities or nursing homes. So they bring in the infection and spread it in their many places of work. So can you talk a little bit about that and how important this is?
Thank you, sir. I appreciate it, and I'm privileged to serve your community. I think you've raised what is the critical issue, which again is the gasoline to COVID-19 match. And I want to say I don't think this is just a byproduct. I think it's part of the system design in that the way long-term care pays for its employees is at the lowest possible rate, and then at the same time says we can't get staff. You have to pay appropriately for what you are trying to get, which is someone who's been trained, has received appropriate training in person-centered models of care, LGBTQ issues, as well as others, and effectively recruit staff. So when we have staff members that are working at multiple facilities that we know where there are active infections, we cannot be surprised when the disease spreads. I submit to you that you as a Congress did provide additional compensation and did encourage facilities to use that for staffing members, but that has not been done. Or it may have been done on a modest level of maybe $1 more an hour, but that does not significantly compensate for the risk that they are taking. And so I understand when staff members are saying, no, I will not come to work.
Thank you very much. I also have a PPE question, and I think Dr. Grabowski is probably the one that I should direct it to. I still have skilled nursing facilities who are trying to track down PPE material and equipment. And this is like way too long into the process for this to be happening. Dr. Grabowski, did the Trump administration implement a clear, comprehensive plan for distributing PPE?
Thanks for that question. No, they didn't. We really should have nationalized the acquisition of PPE from the beginning of this pandemic. Unfortunately, nursing homes and other long-term care providers were left at the back of the line. So hospitals and other systems were bidding up the price of PPE, and nursing homes just simply couldn't afford it. So it's not enough to simply give them the dollars to purchase this. We actually, in some cases, need to help them acquire the PPE because they just can't afford it at the going rates. And so we could be doing a lot more. And unfortunately, the administration didn't kind of connect the dots there in terms of providing the resources and getting the PPE to the nursing homes and protecting our caregivers.
Thank you very much. I yield back, Mr. Chairman.
Mr. Buchanan. Vern?
Can you hear me now?
Yes, go right ahead.
Well, thank you, Mr. Chairman, for this critical, important hearing today. And I appreciate all our witnesses, very thoughtful. I'm in Florida, and as we've talked about the amount of deaths across the country for seniors, I think nationally it's under 50 or 40%, someone said. Arizona said something about 65%. In our region of the deaths we've had, it's been 85% seniors. So it's a huge, huge issue. I have the 7th oldest district in the country, so I'm very sensitive about these issues. The seniors, many of them in nursing homes and other facilities have been locked down for 3 months. 3 months, the impact is enormous in terms of mental health. As we look forward, and I assume we might have another package, I'd like to think that Congress is going to do more in this space in terms of mental health. And Mrs. Gold, is that your thought about what more should we do in this space to be more helpful going forward?
Thank you. So this is a complicated question. I think it depends on your geography and what's happening in your area. And I don't think there's a one size fits all. In New York State, what we've been doing for phasing of reopening is designating a set of metrics and criteria that are used to determine if it's safe to have visitation. So I think that that's something that you could do possibly in the summer months, maybe have it outside. I think there's a lot of things that could be thought about. We have tried utilizing the telemedicine option or the telecommunication. We actually purchased iPads for our residents, but the facts are that a lot of them are not, even with assistance, they are not able to use them. They don't really understand what is happening in that space because it's different than what they've experienced in their life. And so I think it's going to take a group of people coming together and coming up with common sense metrics and working together as a team, but also looking at what's happening in your region, because what's happening here is not the same as what's happening in New York City. So I think that's important to remember.
Well, thanks for that comment. And let me just say, in terms of, I want to talk to Mrs. Kennedy and get her thoughts. I mean, the focus is on nursing homes primarily, but we do have a lot in all our states, especially in Florida, assisted living facilities, memory care facilities, continuing care, retirement communities. So as we look towards PPE and making sure they have the proper resources along with nursing homes, what's your thought? There's 65 members, I think, that have signed on to a letter, including myself, and asked the Secretary of HHS, there's 175 billion for PPE dollars, but we want to make sure these dollars are also going to these other facilities that are critical to Florida, and I'm sure a lot of different parts across the country. But I'd like to get your thoughts on that, Mrs. Kennedy.
Well, thank you, Chairman Doggett and Representative Buchanan. In Arizona, when I talk to the assisted living facilities, they are not getting PPE. They cannot secure it. And the skilled nursing facilities, they were able to get the 30-day supply, but that will run out. It's almost the 30 days that they've had it. So I think really prioritizing your funding to make sure that at the very beginning that these facilities are getting adequate PPE. It's just essential to being able to stop the spread.
But what about, in terms of assisted livings and memory care? Do you think it seems like they're getting a token amount? Seems like they need some additional dollars. Is that what you're saying?
Absolutely. That's exactly what I've been saying. And, at the state level, it's like if they're getting resources, are there guardrails to make sure that those resources are being spent where they should be spent? This should have been the very number one priority is PPE and testing in our all long-term care facilities, not just.
There we go.
Yeah. Mr. Chairman, can you hear me?
I can, but I can't hear the witness.
Okay.
Let's see if
Well,
Go
let me
ahead,
do this.
Vern.
I'll yield
Can you
back.
hear me?
I can
Okay.
hear you.
Yeah.
I
Ms.
think I had some, I think I had some connectivity problems. I don't know
Okay.
what you heard and what you didn't hear.
You want to ask repeat so he gets his full answer?
Yes, I mean, you asked regarding the distribution of PPE to assisted living facilities. I think that is an extremely major priority. And, the skilled nursing facilities are getting some resources, but the assisted living facilities, because they're not regulated under CMS, they're getting left out. And we have 147 skilled nursing facilities in Arizona, and we have over 2,200 assisted living facilities. So they're not getting what they need. So therefore, the spread is just immense. That's why our numbers are so high.
Yeah. So again, thank you, Mr. Chairman, and I yield back.
Thank you very much. Mr. Blumenauer. Will you unmute, Earl? Still can't hear you there. There you go. No, we lost you again.
There.
You're on.
That good? Okay. Sorry
Probably.
for the, although I'm sure a show of hands would probably recommend staying on mute and being able to collect people's thoughts and get caught up. Mr. Chairman, I really appreciate the hearing that you've put together. I appreciate that you and Chairman Neal have an abiding long-term interest in this. I must say, I find the more we get into this, the more unsettling I find it. Number one, it appears as though that the federal responsibility for resources that we provide and for a function where we ostensibly have some oversight, have some legislative and policy guide rails, it appears as though the Trump administration is in the process of weakening them. And the circumstances where there is virtually no oversight, in part there are challenges, to be sure, in the midst of the COVID-19. But given the sorry track record, given the challenges, and given what the administration has done, I find this extraordinarily disconcerting. I wonder, first of all, if our witnesses, Dr. Grabowski, perhaps you have a sense on this, or Ms. Edelman, in terms of having some standards. You mentioned having some requirements that the resources are actually provided from the federal government resources are provided on actual care. If there is some standard that you would recommend, I see the data that suggests the facilities that have been taken over by private equity institutions that are very good at engineering financially appear to not be very good in terms of providing care. Is there an area here where we should have a special degree of standard that is imposed that you can outline in some specificity?
Yeah, how about I start and then Ms. Edelman can pick up after me. So I very much believe that we need to put more resources into this sector, but those resources don't need to go to private equity. They don't need to go to CEO salaries. They need to go to the workforce. And so I really like what Ms. Edelman described earlier about a medical loss ratio. That's one approach. One approach that we've studied previously is using wage pass-throughs, where you're putting kind of Medicaid dollars directly into direct care staff, directly into wages. And so I would very much encourage the Congress to earmark those dollars for staffing. That's where the money needs to go, not to the private equity groups, not to the CEO salaries. We want to make certain this gets to our caregivers. Thanks. I don't know if Ms. Edelman has other thoughts.
Well, I think you provided part of the framework that I want in terms of where the money goes to a specific purpose. It appears that we are also still shy in terms of providing the necessary protective equipment, and there's a serious problem of testing. Do you or Ms. Edelman have, Ms. Howell, a sense of what we should be doing in terms of mandating these key functions of testing and the necessary equipment? Can we just do it directly?
This is Toby Edelman. I think we do need to have a mandate for testing, and we need to make sure the tests are done on all residents. We know from the Kirkland facility, when everybody was tested in that facility, the majority of residents who tested positive for COVID-19 had no symptoms at all. They don't have high temperatures, they don't have coughs or other respiratory symptoms. So it is essential that we test all residents, and then we can target protective equipment where it's most needed, not just sending it randomly around. The other point I wanted to make is that
I just want to conclude here because my time is almost up.
Okay.
Mr. Chairman, I think that is very, very important that we put the resources there. We have 2.5 million people who go in and out of, who are in these facilities, either working or as residents. And that's before we restate the opportunities for families to visit. And I hope that we can bulk up the support for testing and put the resources directly where we want it and not let it leach out to different patterns of ownership or management, but it's on the ground where people need it.
Thank you very much. Appreciate it, Mr. Blumenauer. Mr. Smith.
Thank you, Mr. Chairman, and certainly thank you to all of our witnesses. This hearing topic is very timely. I want to begin by saluting the workers on the front lines of healthcare, especially those in nursing homes and facilities housing our elderly and our seniors that are unfortunately so exposed to COVID. And I think we are learning a lot. We're compiling data, and I hope that we can use that instructively, looking and moving forward. I know that the hardships placed upon families and seniors themselves are many. It's been mentioned already here. I know, though, that the emotional distress, I hope, does not actually outweigh or overcome even the impact of the emotional distress. I hope is not worse than the COVID itself. And so as we do sort through all of the data and information moving forward, I know that video applications have been helpful. Certainly they do not replace the family interaction and so forth, but I'm glad that video and telemedicine can be, I think, part of our answer in treating patients in place. I know I've been working for some time now on what we call the RUSH Act, Reducing Unnecessary Senior Hospitalizations Act, which would expand the usage of telehealth in skilled nursing facilities through a Medicare shared savings system with the goal of treating seniors in place so that we can reduce the risks facing seniors and also improve outcomes. So in addition to new technologies, I know that we here in Congress on both sides of the aisle worked with the president to quickly allocate resources to the areas hardest hit by COVID and in the pandemic, and interventions that were vital to protecting our seniors and slowing the spread of the disease. And one of those actions involved the creation of the Provider Relief Fund. It's been mentioned here earlier today. It distributed billions in aid to providers throughout our healthcare system, including nearly $5 billion to skilled nursing facilities. As the remaining funds are dispersed, I think it's important to note that I believe that assisted living facilities should be helped with these funds. They have been facing a huge burden because of the pandemic, and certainly the scope of their care is very important during this pandemic and even beyond. So the challenges posed by COVID-19 required significant expansions in the use of telehealth, especially for seniors and vulnerable populations. Because of the highly infectious nature of the disease, that has included a new emphasis on treating vulnerable patients in place when possible rather than transporting them to a hospital or clinic. I was wondering what lessons we have learned so far regarding telehealth and the treat in place initiatives that can continue to be an asset both during the remainder of the COVID crisis and beyond. How important will telehealth actually continue to be for nursing facilities and our seniors after the pandemic subsides? Ms. Gould, would you like to start with that question? Mr. Chairman, I think you were still on mute.
I'm very sorry about that. I wanted to say that, yes, this is actually something that we actually implemented. We stood up and implemented during the COVID crisis. Medicine was not our provider had currently using it primary care centers as well as in our skilled nursing facility. And it is a great option to protect the residents, but also make it convenient for them so that they don't have to leave their space. And I think that it's going to be here to stay. I think that we're going to see this long into the future. I think it serves a great place for residents and for people who visit clinics alike. I think that telemedicine is going to be invaluable.
Yeah. And I mean, obviously, this video interactions to treat someone medically is far different than human interactions with family. How much longer do you think we can go basically excluding family support from the human presence that is absolutely vital?
So my dad has suffered with chronic pain from rheumatoid arthritis for many years, and one of the things that he always talks about is quality of life. And when you can't do things anymore, how difficult it is to enjoy life. And what I'm seeing in our residents when I walk down there and the conversations that I'm having with them is that they are feeling this very much right now. To have someone, grab my arm and express to me how they need to see their family is incredible. And we were trying to do the telehealth visits, and some of the residents have actually had, the family members have decided they don't want to do the televisits with them because it makes the resident more agitated. They're actually more upset that they can't actually see their family member. And so we're trying to do something good, but we're finding that sometimes the reaction is actually adverse. And so I think it's residents dependent, but I think the sooner that we can make common sense approaches to be able to bring people into the nursing homes, the better. But we definitely need to do it in a safe way so that no one's loved one is infected, exposed, or at worst, fatal from that type of visitation.
Right.
Definitely is taking a huge toll on the residents.
Yes. Thank you.
Mm-hmm.
Mr. Chairman, I couldn't hear you nor. Go ahead.
I believe your time has expired, and I'm calling on Mr. Higgins. Thank you for your questions and for the comments.
Thank you.
Thank you very much, Mr. Chairman. As we all know, there are 120,000 Americans dead from COVID-19. There is no treatment. There is no vaccine, despite the fact that this is our nation's third coronavirus outbreak in nearly 2 decades. The federal government failed to protect its people. The United States government response to COVID-19 was late, sloppy, and adversarial. And in the absence of strong federal response, the nation looked to New York and its governor, Andrew Cuomo. The nation looked to New York because Governor Cuomo's response to COVID-19 was early, strong, and unified. Nursing homes and long care facilities are most vulnerable to COVID-19 because most of the people that live there have pre-existing conditions. During this pandemic, the president is trying to kill the only law that protects people with pre-existing conditions. Now let me turn to the states in nursing home deaths. Nationally, 1/3, or a little over 33% of all COVID-19 deaths are in nursing homes and workers who work in those nursing homes. In North Carolina, it was 63%. In New Hampshire, it's 77%. In Minnesota, it's 81%. In New York, it's 20%, 13% lower than the national average, 43% lower than North Carolina, 57% lower than New Hampshire, and 61% lower than Minnesota. Dr. Grabowski, can you speak to New York State's response and its effectiveness relative to COVID-19 versus or compared to the federal government's response?
Yeah, so thanks for that question. Our research really supports this idea that, as you just described, the rates in these different states is really reflective of what's happening in the community around them. So as we look at New York and we look at other states, communities in New York where we saw really big outbreaks in nursing homes, there were similar outbreaks in communities around those nursing homes where the staff live. So it's really about where the staff live, bringing it into the nursing homes. And so I don't, as I said in my opening remarks, I don't point fingers at New York State facilities. Not every decision the state made was great, but on the other hand, the onus for this non-response on the part of our government really lives with the federal government.
Yeah, Dr. Grabowski, let me ask you this. Do you believe that there will be a vaccine by the end of this year?
I think we're putting a lot of eggs in that basket. I'd rather put those eggs in PPE and testing. I don't want to speculate about a vaccine, but I know we can invest with certainty in protecting our nursing home residents. So I think it's highly uncertain whether there'll be a vaccine, but we can know with certainty whether our staff and our residents are protected.
Do you know how long it took to develop a vaccine in response to Ebola?
Probably a lot longer than a few months, I would imagine.
It took 5 years.
Yeah.
Typically, a vaccine is 10 to 15 years before it's fully clinically trialed for both safety and efficacy, and then scaled to the number that is needed to deal with a pandemic, which means all of us. We're all in this. Let me also ask you this. Had the federal government invested back when the coronavirus in 2003 was declared to be the cause of severe acute respiratory syndrome 17 years ago, had we made an investment in the development of a vaccine, would we have a vaccine that could be developed much earlier because of the basic science that we would have relative to a new outbreak of the coronavirus?
I think it's fair to say that we've been behind on our response with COVID for a long time, and you're going often further than I do, but at least I would go back to even when we were seeing these outbreaks in Asia and Europe. We weren't making any steps to protect our nursing homes. We saw Kirkland. We still weren't making steps to protect other nursing homes. It's now June. Have we really put the protections in place for our nursing homes and the individuals that live and work there? I don't think so. So you're right. This has been a longstanding problem, but even over the last 4 to 5 months, we haven't been ahead of this.
Thank you very much, sir.
Thank you, Mr. Higgins. And Mr. Higgins, just to make our record complete with reference to a point you made earlier, without objection, I'll make a part of the record a map, a chart that is prepared by the Ways and Means Democratic staff. The share of skilled nursing facilities COVID-19 deaths as a share of total COVID-19 deaths by state as of this month. And actually, I'm afraid that my home state of Texas was about twice as worse as New York. We had 43% of the share of deaths in the state were in skilled nursing homes, and New York was at 20%. So I offer that into the record along with an explanation of it. And with that, and ready for comment further on New York, I'm sure I would call on Mr. Reed on his own time.
Thank you, Mr. Chairman. Dr. Grabowski, let me just cut to the chase. Are you advocating as an expert in this field that COVID-19 positive seniors should be ordered to go into nursing home facilities like the March 25th order of New York State?
No, I've been pretty clear, Congressman, on that issue that I think that was a mistake, but I did want to clarify a couple.
Well, I appreciate that.
No,
I appreciate acknowledging a mistake. Has the governor ever, Cuomo, ever acknowledged, or the 4 other governors acknowledged that was a mistake to your knowledge, Dr. Grabowski?
No, but what he has explained is that it was consistent with CMS guidance. I'll go back to the March 13th CMS guidance, and if
so you're also misrepresenting the fact on that issue that the independent fact checkers indicated was mostly false, if you're aware of that, correct? So you're saying CMS was at fault for this? Is that what you're saying?
The CMS guidance, I think, is pretty clear on that back from March 13th, and I could just read from it. Nursing homes should admit individuals that they would normally admit to their facility, including individuals from hospitals where a case of COVID-19 was/is present. Now, was it a good policy? I just said, no, I think it was a mistake, but was it?
I appreciate you acknowledge it. So trying to sugarcoat the 6,300, Dr. Grabowski, I appreciate it, but to try to sugarcoat the 6,300 deaths that happened in New York, and I think that number, in my personal opinion, is twice that, to somehow say because we're going to play with percentages that we did a great job in New York is appalling to me. It's offensive to me. And it's offensive to those 10,000 plus seniors and their families that died as a result of that order, in my humble opinion, that we're trying to sugarcoat and whitewash this conclusion. And so I want to get to the order itself because it's critical to me that we understand why that happened, because we have been demanding answers on this question in the four other governors, and Steve Scalise, our whip, is now doing it at the national level. And so, Ms. Gould, you lived this. You were on our daily hospital calls. You and I were talking every day for 7 days a week during this crisis. When the March 25th order from New York State was issued, had you or any of your colleagues in the health networks that you represent, that you work with, that you talk with, that we had on our calls on a daily basis, were you in any way consulted in regards to the issuance of that March 25th order that sent 6,300 seniors to their death in our nursing homes in New York?
No, I was not.
And when you heard about that order that came out, it appears you took unilateral good faith action because your expertise said we shouldn't follow that rule. I believe in your opening testimony, you referenced how your hospital worked with other hospitals to protect those seniors as a result of that situation. So when you got that order, how did you respond to it?
So we had actually talked about this before the order had came out. We were actually prepared for what we were going to do if someone came to our facility with a COVID-19 patient. Like I said, we
Becky, you're kind of breaking up there. I think we're having some technical difficulty, Mr. Chairman.
I believe we are.
Can you hear me now? Can you hear me now?
Yes, go ahead, Ms. Gould.
Okay, I'm sorry about that. We had made a decision that the best place to care for those types of patients, COVID-19 patients, would be at the larger hospital, Cayuga Medical Center. And we also knew that by bringing any COVID-19 patient into even our hospital would be risky because we have so many shared service departments. So people who work in dietary also work in the nursing home. People who work in housekeeping also work in the nursing home. So we had decided right off the bat that we were going to have a different strategy and try to keep COVID-19 patients out of our facility so they would not infect our nursing home patients.
And why was that, Becky? Why were you so concerned about having that COVID-19 come into your nursing home facility?
I think it was all the early reports about the people that were on the cruise ship who had all contracted the virus. And so we were very concerned about the layout of a nursing home. So nursing home layout is very institutional-like, kind of like classrooms that you would see like in a high school. And so it would be very difficult. You have one CNA who is in charge of 3 to 5 residents at a time. And when people are already low staffed, it's hard for them to use proper PPE techniques to make sure they're adhering to infection control. And we just felt like it was too risky.
And as you did that analysis, what I'm hearing you testify to, that you were really trying to separate out separate facilities because you just could not manage the COVID-19 population in a situation where there are negative patients who are senior citizens that are highly susceptible to this. So you were concerned about the location of all of this in one location, were you not?
That is true. And we also felt that the best care for a COVID patient would be at Cayuga Medical Center for their care as well, but also to protect the nursing home residents.
And why was that? Because of the expertise in the medical center that they had?
Yes.
And so going forward, if I am surmising your testimony accurately, one of the recommendations I'm hearing from your real life experience is that we should make sure that when the virus comes back, that we get the seniors isolated in separate facilities, and that we get our parents and grandparents the best care that they possibly can by the medical facilities that can deliver that care to them, or those personnel. Is that fair input?
Yes, I think it would be wise for us to make regional networks where we can actually have the COVID patients taken care of in the proper setting and try to keep them out of the nursing homes if possible.
And would you recommend ever that we consider an executive order like March 25th directing COVID-19 positive parents and grandparents to be forced to go into a nursing home? Would you ever support an order like that ever again?
I would not, and I don't believe Governor Cuomo would either.
Okay, and I would hope he doesn't, but as he indicated to the Today Show and national press, that he felt that
I
order
believe
was
your
the
time
correct
has
order.
expired.
It was the correct order then and the correct order now going forward. Thank you, Mr. Chairman. I yield back.
Thank you. Ms. Sewell. Ms. Sewell? Well, we either have technical difficulties there or some problem. Let me call Ms. Chu. We'll come back to Ms. Sewell.
Well, thank you. The COVID-19 pandemic is far from over, and nowhere is that more evident than in my home state of California, where cases have jumped nearly 70% in 2 days. Los Angeles County, where my district lies, is a hotspot with 41% of all the new cases in the last 2 weeks, despite making up only a quarter of the state's population. And that means that the nursing home residents in my district are facing an especially high risk at this moment as cases climb in the community around them. And what is really disturbing is that so much of it's related to staffing. An upcoming study from the University of California, San Francisco has shown that there's a direct correlation between nursing home staffing levels and the likelihood of COVID-19 infections. This study found that nursing homes with total nursing staffing levels under the recommended minimum were twice as likely to have residents with COVID-19 compared with those that met or exceeded minimum nursing staffing levels. So, Ms. Hashek, I was horrified by the conditions that you described. I cannot believe that there'd be such a lack of PPE and the lack of information on who had COVID-19 in the facility. And I'd like to ask you, what are the practical issues that arise when a nursing home does not have sufficient staff?
Thank you, Ms. Chu. What happens is the CNAs on average, on a good day, if we're staffed properly, they have anywhere from 9 to 10, 11 residents. When they're short staffed, they can have up to 15, maybe 16. As the nurse on the floor, I can have up to 30. Sometimes the acuity is not looked at these residents because they may have their acuity, they may have to have 2 CNAs, sometimes 3 staff members due to possibly behavior. There have been plenty of times where I've had to stop my own med pass to help my CNAs, that regardless of maybe giving that resident a shower, helping that CNA, give personal care, be in that room with that other staff member. There's a lot of times we don't get a break. There's times that we've missed our lunches. There's been many times where I have my normal hours are 7 to 3. There's times I've left at 7 o'clock in the evening.
Yeah, and that's what you described is why I am an original co-sponsor of the Quality Care for Nursing Home Residents Act of 2019, introduced by Jan Schakowsky, which would institute minimum staffing and care levels for nursing homes under Medicare and Medicaid. So, Ms. Edelman, how has CMS under the Trump administration weakened the ability to enforce sufficient staffing for nursing homes, including during the COVID-19 pandemic? And why is it necessary for nursing homes to resume submitting staffing data through the payroll-based journal system? What would be the downside to making the CMS waivers related to staffing permanent?
Thank you for that question. It's complicated and extremely important. The staffing information that is submitted by facilities now through the payroll-based system are much more accurate than the information we had before when they were self-reported. And what they've really shown is that there are very inadequate numbers of staff in facilities, particularly nights and weekends. But even so, the federal staffing standard is pretty minimal by itself. It's a requirement for one registered nurse 8 hours a day, 8 consecutive hours a day. Otherwise, some licensed nurses around the clock, but sufficient staff. And that's not a standard that is enforced. And so if CMS does not let us know how many staff were actually in the facilities, if they do not require facilities to give the payroll-based data, we will never know how many staff we were there. We will never know how the residents were assessed. We won't be able to figure out what went wrong and how to fix it. So we need to have essential, important information, and it has to be accurate and comprehensive. I know Dr. Grabowski has been concerned about the information that was released June 4th about the numbers of cases of COVID and the numbers of deaths. Those numbers are also extremely inadequate and inaccurate. We need accurate information.
Thank you for that. Appreciate it. And I yield back.
Thank you very much. Mr. Kelly? Mr. Kelly? Okay, let's see, Mr. Holding.
Thank you, Mr. Chairman. As we all know, this virus has created unprecedented challenges to providing healthcare services. Elective procedures have been canceled, and Americans, especially senior citizens, have been cautioned to avoid hospitals and clinics as best as possible, creating major disruptions to the vital routine procedures and checkups. And as some of you, including my colleague, Mr. Smith from Nebraska, have hit on today, these disruptions have forced us to rethink how providers can most effectively treat patients, and has also spurred major innovations throughout the healthcare space. And the institution of telehealth provisions especially has not only got vulnerable individuals safely out of waiting rooms, but has expanded access for many of my rural constituents who otherwise face major barriers to basic care. I'm proud to say that in North Carolina, many healthcare stakeholders have already begun to embrace telehealth expansion and are working to improve its implementation. Blue Cross Blue Shield of North Carolina, for example, has announced an extension of its expanded reimbursement policy for telehealth visits through the end of the year to continue collecting data for further improvements. Going forward, we must continue working to refine these services so that groups like senior citizens that regularly face access barriers can take full advantage of them. Likewise, I believe immediate telehealth expansion during this emergency is vital to protect nursing homes, which house our most vulnerable population. Rather than risk exposure to infected individuals, seniors in nursing homes should be able to receive an array of care of services virtually, which is why I support policies such as the Access Act that provide grant funding to facilitate the development of telehealth capacities in nursing homes. So, Ms. Gould, you spoke favorably about your experiences with telehealth and using it in your facilities. So I wonder if you could expand a little bit on that and tell us, what are the barriers to you using telehealth even more in your facility? Tell us anything that you think that we could be helpful in reducing those barriers, whether it be reimbursement rates or regulatory hurdles that you've got to face for using telehealth. I'd be interested in hearing your thoughts.
Okay, that is a good question. So I think one thing you have to remember with telehealth is that the patient is not in front of you, so it has to be used in the right setting. So depending on what care or what the patient or resident is being seen for, it may not be appropriate for telehealth. Reimbursement is definitely an issue with telehealth. Can you guys hear me? My whole screen went blank there.
Yeah, we can hear you.
Okay. Reimbursement is definitely a hurdle and has actually been a barrier for some to moving towards that. And I think that we've enjoyed that CMS, thank you very much, has increased the reimbursement during this time. But I think that there are other tools. I think other people have more robust telehealth systems than what we probably have, being a critical access hospital. Our pockets aren't really deep. And so I think having programs where you could buy additional tools to be able to do telemedicine more proficiently would be helpful.
Right. Thank you very much. Mr. Chairman, I yield back.
Thank you very much, Mr. Holding. I will go back to Ms. Sewell, and as is our ordinary practice at this point, in order to maintain balance, we'll go to 2-to-1. So I'll do Ms. Sewell and Mr. Evans, and then go back if Mr. Kelly is available. If he is not, then to Ms. Wolarski. So Ms. Sewell?
Yes, Mr. Chairman, can you hear me?
Yes, thank you. Please proceed.
Thank you again for hosting today's hearing on the devastating impact of COVID pandemic on our nursing homes. It's becoming abundantly clear that we as policymakers, along with CMS, HHS, and other states, must take responsibility for fixing our deficiencies so that our nursing homes are better equipped with what they need now and into the future. My congressional district in Alabama has been disproportionately impacted by the COVID-19 pandemic. While the 14 counties of my district make up 26% of the state's population. We account for 40% of the state's COVID deaths. The pandemic has laid bare the historical inequities that exist in our healthcare system for Black Americans. My constituency is painfully aware of the pervasive systemic and institutional influences that have contributed to their disparities. We've also seen study after study over our nation's nursing homes are not immune to these trends. They are largely segregated, and nursing homes serve higher minority populations that serve higher minority populations are more likely to be overcrowded and to have lower quality ratings. I'd like to thank our guests who've spoken so eloquently about the disparity, the disparate impact that this pandemic has had on communities of color, specifically the Black community, and the need for national demographic data. We need this data. It's critically important. We know that too often our COVID deaths are concentrated in our nursing homes. And I've spoken with the nursing home administrators in my district in Alabama, and it's clear to me that too many of them are not equipped with the resources they need to stop the spread of the virus. They will continue to struggle if we do not provide more resources like those in the HEROES Act. I joined Representative Pascrell and Panetta in addressing a letter to the Administrator Verma, underlining the dire need for our nursing homes to have additional federal support and guidance. The letter asks whether HHS and CMS plan to study the relationship between race and health outcomes in nursing homes that have had COVID-19 outbreaks. As a representative of a majority district in Alabama, I can't stress enough how critical it is to figure out why there are disparities and what these nursing homes can do better to protect our constituents. If CMS doesn't have a plan to do so, I ask that we, Mr. Chairman, must have the leadership from the congressional leaders in order to do something about it. We've seen too many disparities, and enough is enough. I think it's critically important that we address it now. The HEROES Act includes a provision to direct HHS to allocate money for strike teams to help facilities manage these outbreaks, which I think is a good first step. Outside of collecting more data to underscore what we already know is true, that this pandemic has disproportionately impacted minority communities, what can we do, or what recommendations would these witnesses provide Congress to do about this health disparity? In particular, I'd like to ask Mr. Grabowski if he would address the workforce side of this. I've heard from too many of my nursing home administrators that staffing shortages are an issue. And so my question is, what recommendations would you make to address these workforce challenges as we continue to endure the COVID-19 pandemic? First to Dr.
Thank you. This is a great question around workforce shortages. We're seeing that across the country. We had some of this before COVID, but it's just been magnified in the post-COVID period. I would point towards several things that we can do. The first is upping the pay. That's pretty obvious. We need to put more dollars in the pocket of those caregivers. Two, we need to make certain they have the right benefits like sick leave and health insurance and life insurance, just making certain that they have those benefits. And then third, we need to recruit new individuals into this workforce and then retain them. And I've been advocating really strongly that we need to go out. We have lots of individuals right now that are unemployed. We need to match those unemployed individuals with jobs in nursing homes and get them trained and ready to work, such that they can help out, because we're going to see only more shortages as this pandemic continues.
Would any other of the witnesses like to address the workforce challenges and recommendations that they can make to Congress?
This is Toby Edelman. Yes, I think we need to require specific staffing ratios in nursing homes. We have seen for 30 years now the standard of sufficient nurse staffing, and it's not enough. And what we see a lot is that nurse aides have not just 15 people, but 20, 25 residents that they're responsible for. And when a typical problem that I have read about in cases is a resident who needs 2 people to be transferred, and the aide is looking for another person, but there's nobody around. The aide tries to transfer the resident from the bed to the wheelchair independently, all by herself. They both go down on the floor. The resident breaks a hip. The aide gets fired. It's considered her fault, although the reason she did it is there was nobody else around. We need more staff, and we need to mandate those staffing ratios and the professional staff, the registered nurses, to make sure that residents get the care they need and that there's enough staff to provide that care.
Thank you,
Thank
Mr.
you very
Chairman.
much.
Thank you.
Thank you, Ms. Sewell. Mr. Evans.
Thank you, Mr. Chairman. Appreciate this opportunity. Dr. Gavoski, you're probably going to think that that my good friend from Alabama and I are tag teaming you, but I represent a district in Philadelphia, and there's some commonality with what she was describing with what I want to also talk about. I want to talk about the issue of disparity with race and income when it comes to nursing home care, or have you talk about it. And really ask the question is, has inaction at the federal level helped to deepen the disparities? That's first and foremost. Secondly, Dr. Witt, all of this discussions about safe openings, how exactly, particularly this committee conducted a hearing not too long ago and talked about how the virus was affecting people of color. Can you just take some time and talk about the issue of disparities of race and income in the nursing home areas? I know that's been a lot of discussion. And has the federal government added to the problem?
Sure. Thank you for that question. So we've had longstanding disparities in nursing home care in this country, with nursing homes treating higher numbers of Black residents, having fewer resources and worse quality outcomes. And we've just seen that exacerbated under COVID. And indeed, when we did research trying to determine which nursing homes were most likely to have COVID in the building, as I said earlier, it was largely about location and the size of the facility. But the other factor that was predictive of having cases was your share of African-American residents. And that's because of, once again, location. And we know that Blacks have been particularly hard hit by COVID in the community. And then that's led to staff bringing it into nursing homes. So this issue has been really critical right now. And I don't think this administration, by taking on COVID, has really helped dampen these disparities. In fact, if anything, it's magnified it. When you don't provide personal protective equipment, when you don't provide testing, the nursing homes that are least able to get those resources are going to be those lowest resource facilities. And so,
so in other words, no matter if it's Alabama or Philadelphia, there's no huge difference then.
That's right. And if it's in the community, it's going to be in the nursing home. And we found that, you're right, in all sorts of states all around the country and all sorts of communities.
Is there any specific kinds of strategies, if you had the ability to recommend, of things that you think need to happen?
Absolutely. So I would go back, and I know we keep beating this drum, but it's so important. Our secret weapon against COVID is personal protective equipment. It sounds so simple. It's almost like we've had the answers to this test now for 3 months, but we don't want to use them. We know what works. Let's get every nursing home in the country adequate PPE. Testing of staff and the residents is also a must. And we just talked about workforce support. I also think cohorting is very important. And how do we keep, when nursing homes have outbreaks, how do we keep COVID positive residents separate from COVID negative residents? That's really important as well. But you started at the most important thing, supporting our workforce and getting them PPE and testing.
I thank you, Mr. Chairman. You're back to balance my time.
Thank you, Mr. Evans. Ms. Bolarski.
Thank you, Mr. Chair, and thank you so much for allowing me to sit in on this incredible hearing. I appreciate your allowing me to come and be a part of it. So the coronavirus pandemic has affected the whole world, but there's no question its impact has been felt more severely in some population than others. Nowhere is that more evident than in nursing homes and long-term care facilities. The Foundation for Research on Equal Opportunity estimates that although nursing home residents make up only 0.6% of the U.S. population, they account for 43% of coronavirus deaths. Some who track these numbers put that percentage even higher. The U.S. is not alone, with this relatively small percentage of the population accounting for 49% of coronavirus deaths in Sweden and 82% in Canada. It's easy to see why there is such a challenge. Coronavirus spreads most easily indoors at close quarters and is deadliest among the elderly and those with underlying conditions. Nursing homes and long-term care facilities are at a perfect storm of the biggest risk factors and thus require a higher level of care. New York Governor Andrew Cuomo likened the spread of coronavirus in these facilities to, quote, fire through dry grass, which makes it all the more puzzling that his state forced nursing homes to admit patients who tested positive for coronavirus. This policy effectively seeded burning embers into dry grass. New Jersey, Michigan, Pennsylvania, Connecticut, Massachusetts, and Illinois produced some form of these same policies too, with devastating effects. These 7 states account for 60% of our nation's nursing home deaths. According to a recent ProPublica article, Michigan has lost about 5% of its total nursing home residents to coronavirus. In New Jersey, that figure was a staggering 12%. By contrast, California had a forced transfer policy, but reversed it in 2 days as it was able to limit its deaths in nursing homes to 2%. Florida banned these transfers from the start and has lost 1.6% of its nursing home residents. Regardless of the state, each and every one of these deaths is a tragedy, but it's clear that some states mismanage the response and ignore the warnings. These misguided policies deserve close scrutiny, and the leaders who put them in place have a lot of tough questions to answer. Pennsylvania's top health official took their mother out of a nursing home as she was stated forcing into nursing home to take these positive patients. That's insane. 3 days after Michigan reported its first coronavirus case, the State Nursing Home Association recommended to Governor Gretchen Whitmer that the state use empty facilities as quarantine centers. That was ignored. Governor Cuomo scrubbed any mention of his failed nursing home directive off the state's website, manipulated New York data to understate the true scope of the deaths, and at every step tried to wish away any responsibility for this failure. Now is not the time to look the other way. Now is the time to look closely at the response and figure out what went wrong. Ms. Gold, I sit on the select subcommittee of the coronavirus crisis. A few weeks ago, the subcommittee held a briefing on the topic of coronavirus in nursing homes. Some of my colleagues contended that New York's nursing home problem wasn't a result of forcing facilities to take positive patients. Since you're on the front lines, I want to know what you think. Do you think forcing facilities to take patients that tested positive for coronavirus did more to put patients and employees at risk than any other issues your facility has seen during this pandemic?
So I do think that forcing facilities to take COVID positive patients is definitely risky. We did have plans to cohort patients, as Dr. Grabowski talked about. Lack of PPE is also a concern. But from my perspective, because COVID is so low in our area, I think the biggest risk is somebody outside, someone who works facility actually bringing it into the facility. Doesn't know that they have it, that is an asymptomatic carrier, bringing it into the facility. I think Governor Cuomo's order for all of us to wear face masks whenever we're in the facility was a good order, and I think that it does help and it does prevent the spread. But I cannot agree that COVID positive patient in a nursing home is a good idea.
I appreciate that. And I just wanted to throw this out really quickly. I know we've all talked about PPE today. I just wanted to throw out that in the state of Indiana, so many manufacturers are making domestic produced PPE inside of Indiana. Our governor pulled X amount of a percentage of those off of there. And for every company going back to work and opening up in the state of Indiana, they were able to purchase through what's called the marketplace now, set up by the state of Indiana for manufacturers in our state, a lot of them in my district, that are running extra amount of PPE specifically for the companies inside of Indiana. And I would lend that model to any governor in this country who's trying to open up, thinking open up, or hopefully would take this information, open up, and provide what's actually being produced inside the state into a marketplace for that state and for their employees. And with that, Mr. Chairman, again, thank you, and I yield back.
Thank you. I'll be calling on Mr. Schneider now, then Mr. Horsford, Mr. Kelly, Mr. Pasquale, Mr. Davis, just to give you an idea of where you are in line for questioning. Mr. Schneider, would you proceed?
Thank you, Mr. Chairman, and thank you for having this hearing, but I also want to thank our witnesses for staying with us today. As you've all discussed, we have a national crisis raging through our senior care facilities. Serious problems existed before COVID, But as Mrs. Howell eloquently said, COVID was the match applied to gasoline of years of neglect. In my home state of Illinois, more than 50% of the COVID-related deaths have occurred inside our nursing homes. In Lake County, which I represent, 47 different senior care facilities have reported an outbreak, totaling more than 1,500 positive cases and tragically 250 deaths. And Lake County isn't even the hardest hit in Illinois. I've spoken to nursing homes and public health officials in my district, and the number one issue, the number two and number three barrier they cite for effective infection control is lack of adequate testing and PPE for both patients and staff. The supply chain broke early in this crisis and remains broken today. According to a recent survey, more than 15% of senior care facilities have less than a week's supply of masks and gowns, and that number has only gotten marginally better over the last few weeks. The facilities that are able to get supplies are paying exorbitant prices. A gown that cost 31 cents before the pandemic can now cost up to $17. And an N95 mask that cost 65 cents now costs upwards of $6. That's 10 to 15 times the price. And that increase is costing billions on a national scale. Worse, it's costing lives for the people who cannot get the protection they need. Our administration's response has failed to meet the moment with tragic consequence. For instance, FEMA recently distributed care packages with a 2-week supply of PPE to 15,000 nursing facilities around the country. It's one issue that the administration celebrates sending 2 weeks of critical supplies at a time when we're in the middle of a month-long pandemic. But it's worse when those supplies arrive, they're unusable, they're not medical grade, they're of no use. Staff describe surgical gowns more like tarps than gowns, and masks billed as N95s made of cloth. Both are useless in a medical environment. These issues aren't new. I raised these concerns in February and March with Secretaries Azar and Mnuchin. Our supply chains broke down early in the pandemic. If I can ask Ms. Hashik, can you give us a brief description of how the supply chain has affected, or the lack of access to PPE has affected your work?
Thank you, Mr. Schneider. We've had to, you saw in my testimony, I've personally obtained my own PPE. There have been times where some of my co-workers were wearing ponchos just to cover themselves. We're wearing our N95 masks weeks and weeks at a time. And it's still, we have to sign for them each time we get a mask. The residents that they're starting to recently allow them to come out of their rooms, because I am considered a clean wing at this time. They need their masks, and it's just very frustrating and difficult because we have to fight with them. Staff members have gone to administration as far as where is the PPE. We're trying to protect ourselves. We're trying to protect our residents, and I think that's most important. It's frustrating. It really is.
I understand.
It's like we're not having a winning battle.
It's awful, and the fact that you're buying your own is even more astounding to me. Dr. Grabowski, can you discuss the administration's response, as well as what you think Congress should be doing today to ensure that we have the PPE we need in the current crisis this summer, and as it looks to have a spike in the fall?
Absolutely. We need to, as you suggested, nationalize the supply chain. We can't have nursing homes or states bidding against each other, bidding against hospitals. We need to basically consolidate and purchase collectively. I would prefer even a process where the federal government was doing the purchasing and then providing the nursing homes directly, as they were going to do for those 2 weeks, which ended up not going the way we had all hoped, with unusable PPE. Even in one case, I read in the Wall Street Journal, glorified garbage bags. That should offend all of us. We need to make certain we're getting top PPE to nursing homes. This is where COVID is at its strongest. This is where it is at its most dangerous. Let's get our nursing home workers the PPE that they need and deserve.
Great, thank you. I think you use a key word. We should all be offended. The greatest nation in the world should be able to do this. I will share that with my colleague, Catherine Clark. I've introduced legislation that was also included in the HEROES Act to designate a medical supply chain coordinator to centralize that function to make sure we're getting the supplies, what we need, where we need it, as we need it. With that, Mr. Chairman, I yield back. Thank you.
Thank you, Mr. Schneider. Mr. Horsford? Mr. Horsford with us?
Yes, thank you, Mr. Chairman.
Oh, thank you. Good.
This is such an important hearing. I want to thank you, Chairman Dockett, for leading this hearing, and to all of our witnesses for sharing your expertise. I've shared with this committee before in the past that providing quality care to seniors is a deeply personal issue for me. When I was just 9 weeks old, my grandmother suffered a debilitating stroke that put her in a coma for 6 months and left her paralyzed on the left side of her body when she came out. She needed around-the-clock care and relied on long-term services and supports provided through Medicaid. Because of her stroke, she spent 27 years of her life in a nursing home until she passed away in April of 2000. I spent much of my childhood and early adulthood in those nursing homes, visiting my grandmother every week. And I remember as a boy that probably wasn't more than 8 years old, I told her that one day I would be in a position to raise the issues about the lack of care for so many people that are in nursing homes. And today is that day. I can only imagine how heartbreaking it is for families who have loved ones in nursing homes who are not able to make those weekly visits during the coronavirus pandemic. Just yesterday, I conducted a telephone town hall in my district, and I spoke with Deborah from Las Vegas, who before coronavirus visited her brother in a nursing home 5 or 6 times a week. Now, it has been 4 months since she last saw him in person. Deborah shared that she constantly is worried for her brother's safety and health, and I have heard the stories from seniors across my district who express how lonely and depressing this experience has been. Well, to the frontline doctors, nurses, and healthcare workers, I've heard how trying this time has been to meet the challenges of obtaining PPE testing and staying healthy. And with all due respect to my colleagues on the other side of the aisle, there has not been a strategy from this administration. And in fact, the PPE that was delivered has been hoarded by many of the very facilities and have not trickled down to the frontline workers who've needed it the most. So to all of those healthcare workers on the front lines, I just want to say thank you. Thank you for adhering to these very tough guidelines and for fighting for our family members in these situations. I know you are working hard, and I know that we can work together to address the troublesome changes discussed that are in this hearing. And it is, quite frankly, outrageous that our family members and those who are living in nursing homes are in these conditions. But I want to begin with the question for Ms. Howell, who I'm thrilled to see as a fellow native Nevadan and a graduate from the University of Nevada, who's on our panel today. So go Wolfpack. But in your testimony, you shared that facilities with a significant number of African Americans and Latinx residents, irrespective of facility size, rating, or location, are twice as likely to have coronavirus infection as those facilities whose residents are white. So can you discuss some of the long-standing health disparities these populations face and how COVID-19 can impact their life expectancy and health outcomes? And further, can you touch upon the reporting challenges faced in those facilities?
Thank you, sir. I too had a grandmother who was on Medicaid who spent time in a skilled nursing facility. And I would say what happens is we have individuals who have depended on a healthcare system for years provided by Medicaid, and they simply do not have the money. And so for that reason, they are sent to healthcare facilities that put them directly in line with the disease. Yet there are less expensive and more enriching places that they could live through the use of home and community-based waivers where someone could be supported in the home. And I think what happens is these individuals have a built-in distrust of the system that has not served their needs. And so inherently, these folks are told that they are going to have to be discharged, or no, we can't take care of you, or you'll have to stay in X facility that maybe doesn't actually have a great rating because it was the only facility that would take a Medicaid resident. And I think that we've built and deepened the structural system where folks who are Native American, Latinx, and I would also add African Americans, really do not have the care that they deserve. And because of the continued entrenchments of the social determinants of health outcomes, they already had the diseases such as diabetes and other vasculars that just put them at risk for this disease. So what I think is we're talking about sort of reimbursement and care strategies, I think we need to look at the disparate ways in which the state and federal government create unnecessary competition to incentivize certain kinds of residents versus other residents.
Thank you. Chairman Doggett, I just want to conclude by saying, as you know, we've introduced the Nursing Facility Quality Reporting Act of 2020, a bill that I sponsored, and it's included in the HEROES Act. I look forward to working with you and any other member of this committee and the Senate in advancing these important measures. Our family members and those in these nursing home and long-term care facilities deserve nothing less. Thank you for your leadership, and I yield back.
And thank you for your work on that legislation. And Mr. Kelly.
Chairman, can you hear me okay?
Yes, sir.
Okay, all right. I'm never sure whether I'm hitting the right button. First of all, thanks for having the hearing. I appreciate it. One of the things that makes it tough when we have hearings like this is it turns into a political issue as opposed to a really good policy issue. If we had had this meeting in July of 2019, I wonder if we would have had the same concerns about administration not reacting to a pandemic that nobody saw coming. And I listen, and I'm at this point in my life, I know that hindsight's always 2020. And I know it's easy to blame the previous administration. I don't think there was too much preparation going back several administrations for the idea that we may have a pandemic some way. It just wasn't on the charts and nobody saw it coming. It happened though. Now, change does take place during a crisis or a tragedy. So for all the members, the panelists that came in, I mean this sincerely, thank you for taking time out of your life to come in here and talk with us, or at least come on the screen with us. But in your own operations that they're doing right now, the whole gamut of what it is we're trying to do. I know in Pennsylvania, 67% of the deaths from COVID are taking place in the facilities, the nursing home facilities. And early on, it was really hard to understand. Our governor Governor Wolf told people, listen, you nursing homes have got to take these people in, even if they are COVID positive. It is a must. You have to do that. Then they backed it off after they saw what was happening and say, well, you can kind of decide for yourself, kind of figure out for yourself what you have to do. So it was one of those things where directing people to do some kind of a ship without a rudder and letting people decide what they should do. Even our Department of Health, the Secretary of Health, took her own mother out of a nursing home and put her in a private hotel once they had made this decision that you had to put people in nursing homes, even if they're COVID positive. So this is just across the board. I don't want this to be political, as we waste so much time bashing whatever administration's in office. Let's talk positively. What could we do going forward? Because I'd rather know what it is we can do, why we have to do it, and how we would then do it. From each of you, if you can just do us a brief summary of what you would do now, knowing that we have this pandemic and the possibility that there could be a relapse and the possibility that there could be something else released into the world again that we didn't know about until January, February of this year, had no hint of it happening. I don't really want to blame it on the previous administration, this administration, but any administration going forward, we should probably have an idea that we need to have stores of product in place that we can use. The fact that we've used other producers around the world for production, that was a policy that we took because we like buying things that were cheaper. So if you can, each of you, if you can just take a couple of seconds, what would you do from this point on, as opposed to blaming somebody in the administration for not doing something that nobody saw coming? An impossible thing, but I know we're in a political world and November 3rd is not that far off. So anyways, Becky, why don't you talk a little bit about what you could do up there in New York?
So I think I said some of this already, and I don't want to repeat myself, but I think coming up with strategies, regional strategies, where hospitals can work together to keep COVID-19 patients out of nursing homes would be a first strategy. Obviously, if there's nowhere else to place individuals, you may have to put them in the nursing home. That's a reality that we have to accept. I think understanding the difference between the burn rates of what staff use for PPE when they do not have COVID patients versus what the burn rate is of PPE when you do have COVID patients is really important, because it's drastically different based on what type of patients you have in your facility. And so we need to be prepared for that worst case scenario. So how much PPE do we need to have if we do have the worst case scenario of having cohort patients within our facility? And I do think ensuring that we have enough staff in order to care for those patients and provide proper care and proper training. There needs to be proper training of how to don and doff PPE, of how to use proper infection control inside the facility. All of those things are going to be majorly important, not only to the fall, but also to any type of outbreak in the future of any type of droplet precaution that we might encounter here in the United States.
Very good, very good. Anybody else? And one of the things I've always heard is that in our emergency rooms, we are woefully unprepared for something like this happening in the future. Any kind of biological warfare that would take place if there's very few hospitals equipped to handle any type of large numbers of inpatients. So I'm sorry to take up any time, but anybody else, please, Dana, anybody that wants to weigh in, please weigh in because you're the experts in this.
Thank you. Thank you, Chairman. Representative, this is Dana. I don't know if you guys can see I'm having connection problems, but I can see some of you. The one area that I would also say is we need to publicly report on a daily basis whether a facility has COVID-19. I mean, that goes back to the community spread, and not sharing that information and not being transparent, I think has led to more spread. I know we had one facility in Chandler when I went onto a Google map and saw that there was 3 other facilities. I knew it wouldn't be long before those facilities also had COVID in them. So transparency is critical.
Thank you.
Great point.
Thank you very much. Thank you, Mr. Kelly.
Thank you, Chairman.
Mr. Pasquale.
Hi, thank you for putting this together, Mr. Chairman. I think it's excellent. The members have been really great on both sides. The arc of the moral universe is long, but it bends towards justice. That's the second time I quoted Martin Luther King Jr. today. I think it's so appropriate here. Nursing homes have been devastated by the virus. Nearly 30,000 residents across the country, including more than 6,000 in New Jersey, have died. This is not a drop in the bucket. There are now over 123,000 COVID-related deaths in the United States. No hoax, Mr. Chairman, no hoax. Long-term care deaths are disproportionate. Nursing facilities comprise only 11% of the cases. They comprise 1 in 3 COVID deaths. These guys have gotten away with murder. And we're here talking about partisan politics? You got to be kidding me. 1/3 related deaths come from nursing homes. And I want to be clear. This was not only because our elderly are more vulnerable to COVID-19. It goes, I think, deeper. The fact that too many facilities across our country have been mismanaged for many years. Who is in jail? Nobody. Like the bankers in 2008, nobody. These glaring deficiencies were made worse by this administration. Yes, rolling back nursing home protections. That is a fact. That is a fact. You didn't do it, members. They did it in administration. They rolled back the regulations. I'll cite them if you want me to. In 2017, CMS gutted standards in nursing facilities for infection control, facility assessments, and transfers and discharges. If we would have that record, and if we followed up on it, as the administration was supposed to under the law, we would have known which places were more vulnerable to the disease. We didn't do that. The administration's guilty of this. Administration recklessly disregarded the health and safety of our most vulnerable neighborhoods, our most vulnerable nursing homes. CMS even has a proposal to eliminate requirements that nursing homes employ infection prevention specialists during this pandemic. You can't make this stuff up. What the hell are they doing over there anyway? So I have a question for Dr. Grabowski, and I'd like to say to Melinda Haschek You are truly a first responder. Thank you so much for what you do day in and day out on the front lines. Dr. Grabowski. You're welcome. Many are responsible, Dr. Grabowski, for the outsized impact COVID has had on nursing facilities, including nursing homes themselves. Yet this administration has doubled down on its crusade to make nursing homes less safe. What are the most harmful impacts of deregulation on nursing facility residents, Dr. Grabowski?
Yeah, we need strong regulation here. We have a lot of residents in nursing homes that can't monitor their own care. They can't advocate for themselves. We need ombudsmen, we need regulators, we need family keeping eyes on this. And so when those eyes aren't on the buildings, bad things happen. And we've heard already during this hearing about low staffing and other bad outcomes that can happen. So we need to maintain strong oversight and accountability.
Well, Toby Edelman, senior policy attorney.
Yes, sir. I agree completely that we need strong regulations and they need to be treated seriously.
Quote.
CDC talked about what to do for COVID, and what they said is our guidance is identical to what we say for all infections. These requirements are not new. These guidances are not new. Staff need to wash their hands. That is the #1 violation cited in nursing homes, hand washing. They need to have and use personal protective equipment. They need to disinfect equipment between residents, medically, do it correctly. They need to isolate and identify residents who have an infection or seem to have an infection. These are essential, basic infection prevention and control requirements for COVID, for any infection. They've been around for years. This is the #1 violation cited in nursing homes.
Mr. Chairman, can I say this
last
before I
month
sign off? Thank you, Ms. Edelman.
Thank you.
Mr. Chairman,
Yes.
can I just make one more comment before I sign off?
Yes, go right ahead.
If there are reports and oversight where the CMS is coordinating oversight with the states, with the individual states. So each of these homes, each of these nursing homes gets a report card. What has been done with these report cards? Where are they? How have they been acted upon? I want to know within the next week from CMS, give us what you've done about these report cards, or else every one of you should be fired from the top to the bottom. I've had relatives that have been killed in these nursing homes, and I'm not going to leave this alone, Mr. Chairman, and you're not either. Thank you.
Thank you very much. Mr. Davis. What about what he's talking about? Right there.
Thank you very much, Mr. Chairman, for the opportunity to participate in this hearing. Anything that has to do with health is always of great interest to me, even though I'm not a member of the committee. I've got a question I'd like to ask Mr. Edelman. The Illinois Department of Health recently posted data that over 52% of the state's coronavirus deaths are tied to long-term care facilities, assisted living establishments, and other homes. The highest number of deaths have occurred in Cook County. There are multiple agencies in Illinois that inspect and certify nursing homes in the state, including the Illinois Department of Public Health, the U.S. Department of Health and Human Service Centers for Medicare and Medicaid services. Mr. Edelman, could you speak to where the gaps are in inspection, surveillance, and enforcement, education, and guidance?
Well, thank you for that question, Congressman. For the last 3 months, CMS has said to states, Do not do any surveys. Do not do any surveys except for immediate jeopardy deficiencies, which are 1% of the problems, or targeted infection control surveys. They did infection control surveys, supposedly. On June 4th, they released 5,700, and we looked at them. Only 160 cited any deficiencies, and they called them no harm. How, in the middle of a pandemic, when so many people are dying from infections every day, do we find facilities not having any problems? This is the #1 problem in facilities. The GAO said last month it's the #1 problem, widespread, persistent, way before the COVID-19 problem. So we do not have good oversight. We don't cite the problems, and even if we do cite problems, we don't do anything about them. And that's the real problem. That is the real problem. We just let these issues fester, and now we know the #1 issue, hand washing. Hand washing isn't just a trivial matter. People are dying in nursing homes because the staff are not washing their hands. And I would say part of the reason they're not doing that is that there aren't enough of them. And so people try to cut corners and do as much as they can, as quickly as they can, when they have a lot of residents to take care of. But we need to have better enforcement of these important standards.
Well, thank you very much. And Dr. Grabowski, could you discuss the impact of the separation of ownership of the real estate and the operations of nursing homes on the quality of care received? And I ask that question because there are some who believe that private equity investment in healthcare does not always benefit the patient, and that it has the opposite effect or impact. Could you explore that with us?
Sure. No, thank you for that question. So this has been a trend in nursing homes to separate the real estate from the operations. And we've really seen under COVID how that can be a really risky separation. From an assets perspective, the most valuable part of a nursing home is the real estate. And so the operator still has to pay their lease to that owner while they're not taking in patients like they were before COVID. And so it's become really challenging for a lot of nursing homes to basically operators to pay their bills right now. So the private equity groups are kind of protected while the operators are really challenged. So I think exactly as you described, Congressman, we always worried about sort of the accountability and the transparency of these deals and ultimately the quality. I think we've really seen that come to light here with COVID, where it's a really risky proposition to separate kind of ownership from operators and really thinking about who's accountable all the time, but especially during a pandemic.
If I could just ask you quickly, I've always had some affinity for operators of nursing homes. There are a number of them in the community where I live. I used to be on the board of one that a not-for-profit built and we operated for a number of years. And I must tell you, we caught holy hell trying to operate it and maintain the standards that we wanted to have. Would you say in any way that perhaps the nursing homes have been underfunded, or the reimbursements that they get have attributed to the quality of care that they sometimes provide?
Absolutely. Are there some bad nursing homes out there? Definitely. But it's hard not to argue that low Medicaid reimbursement hasn't contributed to low quality. We've done a lot of studies supporting that link. And going forward, we need to make certain that we're adequately funding nursing homes. And as was stated by Ms. Edelman and others, we need to get those dollars in the pockets of the workers, not CEOs, not those private equity groups you just asked about.
Thank you very much, and thank you, Mr. Chairman. I yield back.
Thank you very much, Dr. Winstra.
All right. Hey, thank you, Mr. Chairman. Thank you, everyone, for being here today. I really appreciate it. And I'm glad we're having this hearing to address this crisis. You know, we face this pandemic. And I can say that in Ohio, we've had a lot of people very committed to taking care of our seniors in their facilities. Interesting story. Staff at 2 assisted living facilities in Ohio even moved into their facilities for 65 days to keep their patients safe. That's incredible. They sacrificed being away from their family for over 2 months to make sure that they're protected. So that speaks a lot to the caregivers, which obviously we need more of at every level in healthcare today. But they put their own safety at risk and out there protecting the most vulnerable. And you know, I even spoke to one Ohio nursing home provider who spent time one morning buying rain ponchos on eBay to serve as PPE for his providers. Now, this isn't acceptable. And, you know, we can take a look at these things. We should do an after action review, find out where we're short, where our challenges are, and how we can do better. You know, and pointing blame, I guess that's bound to happen. Washing one's hands of something, none of those things are solutions. And that's what I really prefer to work on. I have written Secretary Azar asking for additional funding from the Provider Relief Fund for skilled nursing facilities. And I'm glad to see that Secretary Azar dedicated $3.9 billion of that fund to over 13,000 skilled nursing facilities. But you know, speaking as a doctor, the practice of isolating sick patients isn't new. And governors in some states, as we know, mandated that COVID-19 positive patients be sent back to their nursing homes. Dr. Grabowski mentioned that 1 in 10 nursing home patients have died in New Jersey. New Jersey is one of those states. New York had access to the U.S. naval ship Comfort and the Javits Center and still sent patients back to nursing homes. We have to understand why that happened. Send them back to the most vulnerable. I mean, and these weren't federal mandates to do that. You know, these were state mandates. This is a federal, state, and local problem that we have to deal with. But I challenge anyone to ask themselves if they would want to comply with a government mandate to send COVID-19 infected patients home to their home or to an extended family, especially if one of your family members is the most vulnerable. So I'm curious where the advice came for that. Did you consult with infectious disease before making that decision? And the PPE problem, let me touch on that. That is a problem. And I don't know that that problem was better under the last administration or the administration before that. I shudder to think that any of them would have been in a better situation. We were in a bad situation. And why? Because we don't have enough domestic source of these types of things. And I'm working very hard on identifying what our critical needs are so that we can be ready. And we have to find ways as Congress and do our role in making sure we can produce these things domestically and have the minimal amount required and certainly the manufacturing capability for a reserve when called upon in a moment's notice. You know, in my hometown of Cincinnati, we have a health collaborative amongst our hospitals. They were ready to go to our convention center to build a hospital there. And all the hospitals had a role in addressing this. These are the types of things we need to be ready for. These are the types of things we need to talk about. But, you know, we see that majority of COVID deaths occurred in poor performing nursing homes with quality ratings scores 1 to 2 stars. And there's universal precautions for infection. There always has been. And CMS required facilities to have infection control programs in place. You know, I was part of a surgery center with other doctors. We had our infection control program in place. And before I got to Congress, I served on our Board of Health, and we would commonly evaluate and share best practices amongst those in our community that are taking care of people. So we need to take a look at nursing homes and see what succeeded with infection control. Why did some not have a problem and others did? So this, I think, is the path forward, is put pointing fingers and come up with solutions and make sure that we're trying to address the problems that we are facing as a nation that affects everyone. And, you know, there are things Congress should do. And I want to ask Mrs. Gold, I'll choose you. You know, as I said, this is federal, state, local. What do you think Congress should do in order to improve the quality of the poor performing nursing homes? And I yield back.
Were you?
Was I heard?
Yep. I'm not sure she heard. I guess we'll let her give her answer for the record if there's further answer, and I'll call on Mr. Byer.
Mr. Chairman, thank you very much, and thanks all of you for going through this long and really important hearing. You know, one of the first outbreaks that caught our attention, the first one was the Life Care Center in Kirkland, Washington, and that was back in February. And we knew at the time it was going to disproportionately affect older adults. The older, the more dangerous, which is one of the reasons we've had so much trouble having the young people take it seriously. But it wasn't until mid-May that finally the CMS started requiring the collection of nursing home data. It was 2.5 months in. And I know we were talking to our governor every single week about what's happening in the nursing homes. Let us know. The families want to know. It was just a complete shutdown of information. And in a country and a government, a democracy that's completely dependent on transparency. Dr. Grabowski, do you have any sense of what this delay in data transparency has meant to the situation that developed in the nursing homes?
Yeah, thanks for that question. It's really caused two problems. The first is that it didn't allow us in a timely way to know the extent of the problem. We now know that a number of the cases and the fatalities are located in nursing homes, but I really don't think, we obviously had the situation in Kirkland, but we didn't have the broader data to tell us, hey, this is where we should be directing a lot of our resources. The other problem with not having early data was not being able to learn, as the prior congressman just said, about which facilities have cases and which don't, what's working in terms of best practices, infection control, public health, infrastructure. This is just good public health that you have data that you're learning from both your successes and your failures. And this really prevented us from any type of learning.
Yeah, thank you very much. Ms. Edelman, your testimony was fascinating. You get the sense that Trump has been doing the bidding of any industry, his entire administration, eliminating any regulation on industry's wish list, and we're paying for that behavior right now. 2013, the Center for Medicare and Medicaid Services proposed updating emergency preparedness, and you go through in your testimony sort of step by step all the things that were rolled back. Can you tell us concretely how much the rolling back of these regulations may have had an impact on this crisis in the nursing homes that we've seen?
Thank you, Congressman Byer. I think the rollback of the standards of care, the complete lack of information, and no oversight. There has been nobody in nursing homes for 3 months, not families, not the Ombudsman like Ms. Howell. They do such an incredible job advocating for residents, and not the state or federal surveyors. There's been nobody looking at what's happening. And now we see the results. We see the results of what happens to rolling back or not enforcing standards of care that we've had in place for decades.
Ms. Edelman, assume that I've been a small business person all my life. So I'm very sensitive to Ms. Gould's, for example, talking about the cost burdens of PPE, the cost burdens of trying to test your employees. How do you sort out how much of this cost pressure in the nursing homes is because of too small Medicare reimbursement payments or Medicaid reimbursement versus the private equity takeover of what used to be family-run, small business-run homes?
Well, private equity involvement has been a very serious problem. What private equity firms did was immediately cut staff in a number of facilities, and that was good for investors, but terrible for the care for residents. But what private equity firms have also done is sold the real estate. That's the most valuable part of the nursing home business. And they've sold the real estate to real estate investment trusts. Then the real estate investment trusts raised the rent. So the reimbursement that was paid to nursing homes was not as available for staff anymore, or for food or supplies, or all the things that residents really need to rely on. Instead, the money went to the real estate investment trusts. And they kept raising the rents and actually bankrupted the facilities. Facilities went into bankrupt. This is what happened with the Carlyle Group and Manor Care. So that's been a terrible situation. But generally, we just don't require facilities to be accountable for the money we give them. And I would just give an example of Medicare. Medicare is the highest payer. At present, the average rate is $525, $550 a day, up to $1,000. In 2014, the Inspector General looked at all of the residents who were admitted to nursing homes under Medicare in a 1-month period, and they found that more than a third suffered an adverse event or harm. They had medication errors. They had all kinds of problems. There were hospitalizations and deaths that had not been anticipated at all. This is with the highest payer. This is why our concern is not just to give money, but to make sure that the money goes where we want it to go. Medical loss ratios, the other efforts to make sure that money is spent on care for residents and not just taken out by the owners for profits, management, overhead, whatever they want to take it out for.
Thank you very much, Ms. Alderman.
Thank you.
Thank you very much, Mr. Byer. Mr. Panetta.
Great, thank you. Appreciate that, Chairman Doggett and Ranking Member Nunes. Thanks to both of you for holding this hearing. And I want to thank the witnesses for providing your testimony, your preparation, and your experience and sharing your experiences with all of us and with the nation. So thank you very much. Obviously, our nation's nursing homes, their residents and their staff clearly have been at the epicenter of this crisis. As someone who grew up with a loved one in a nursing home, I'm familiar with the general dynamics of a nursing home. I'm familiar with the care that is provided for residents that's necessary. I'm familiar with the love shown by many of the employees at these nursing homes for the residents. But also, and sometimes, I'm familiar with the lack of love and lack of care that can be shown for residents, as well as the isolation that residents can feel as well. Now, I believe this pandemic did more than take advantage of these types of conditions at our nursing homes. I believe it ravaged our residents and it went after the employees. As we've heard, and as you know, as many as 9,600 nursing homes and other long-term care settings in the U.S. have had at least one COVID-19 case. There's been more than 50,000 residents and workers in long-term care settings that have died from COVID-19. And as my good friend, Mr. Pasquale said, that's 1/3 of all deaths nationwide. And to make matters worse, prior to this pandemic, the administration decreased oversight for these facilities, reduced punishment for facilities that commit violations, and limited options for patients and families who seek justice through the legal system. It's those types of decisions that have exacerbated the vulnerability of nursing home residents and staff and left many nursing homes miserably unprepared. That is why I do believe Congress must continue to lead, hold bad actors accountable at all levels, protect residents and staff so that they can continue to live and love and be loved. Now, last month I introduced the SOS Act, the legislation that would fund nursing home strike teams for additional nurses to go into facilities at the request of the facilities during the COVID-19 pandemic and assist with staffing and caring for residents. This concept is already working in several states in response to spikes of COVID-19, and it's deployed mainly for nursing homes that have had a hard time finding employees in the first place, not just during the pandemic. So, Dr. Grabowski, I'm not going to ask you a question because you've been getting a lot of questions, so don't worry about it, all right? I'm going to ask Ms. Kennedy this question prior to getting to this point of having strike teams comes in. Is there anything that Congress can do to help increase or incentivize staffing at skilled nursing facilities?
Thank you. Thank you, Chairman Doggett and Representative Panetta. I do believe that some facilities are offering hazard pay, and I think that that is definitely something to consider. And I think that especially in times of crisis, being able to offer an incentive for staff to be able to get a little bit of extra money is helpful in times of crisis.
Right. And Dr. Grabowski, don't take it personally. You've just been doing a really good job, and there's a lot that you know, and I appreciate it. Trust me. But I want to get to somebody who hasn't talked much, and I think she should talk a little bit more, and that's Mrs. Satterwhite. Ms. Satterwhite, thank you very much for what you've said. and I appreciate you being here, and obviously sorry to hear what happened to you and your brother. What should Congress know about your experience with your brother's nursing home as we consider ways to prevent patient harm in nursing homes moving forward, and even during and even after COVID-19?
Well, thank you for the question. I think that if we could get more testing done, here in Texas, they're not testing like they should be. I know that at the nursing home where my brother was at, they just tested the staff and the residents a few weeks ago. My brother did not get tested until he was running a fever and coughing. So testing is a definite must in these nursing homes. They need PPE. The workers need to be protected. They can't do their jobs if they get sick. And the residents can't take care of themselves. So they need the workers there to help them. But testing definitely has to be done more frequently for the
Great.
workers and the residents.
Thank you. Thank you. Thank you again, Mr. Chairman. I yield back.
Thank you, Mr. Panetta. Mr. Estes, thank you for waiting. And please proceed.
Thank you, Mr. Chairman, and thank you to all of our witnesses for joining us today. This is a very important topic that we need to talk about and address and help support our most vulnerable citizens. You know, every day medical professionals put themselves at risk to serve their community and battle against our current public health crisis. I've heard from healthcare providers in my district, they need our support now more than ever, and nursing homes especially need assistance as they determine how they prevent the quick spread of virus like COVID-19 in the future, while also maintaining that high quality of care for their residents. Our medical communities should be prepared for future epidemics, and it's imperative that nursing homes have the ability to better protect our seniors. Across the United States, nursing homes and assisted living facilities have unacceptably high rates of confirmed cases and deaths related to COVID-19. Nursing homes have done what they can for their patients, but we've seen troubling actions from public officials. I'm especially concerned that several governors' actions, including New York's Governor Cuomo, that insisted that nursing homes take COVID-19 positive patients. I know that's been talked about previously, but it's one of those issues that just stands out as what's made it worse for so many people. Most nursing homes, of course, don't have the tools or the capacity to handle these patients, leading to devastating consequences. However, I want to step away from placing blame. Instead, let's focus on how do we fix the issues in front of us. In my district, nursing homes have voiced that this crisis has exacerbated an already existing problems, especially inadequate staffing levels. To keep residents and staff safe, nursing homes must send staff members home when they exhibit symptoms of COVID-19. This forces nursing homes to ask healthy staff to work longer and more frequent shifts. The Nursing Home Workforce and Quality Act addresses this problem. Representative Evans and I have introduced this bill to ensure the quality standards of nursing homes are upheld, allow for additional oversight of nursing homes with systemic problems, and address critical shortages of certified nurse assistants. Specifically, the legislation allows nursing homes that have triggered a 2-year ban on in-house CNA training programs to immediately resume such programs when the Secretary of Health and Human Services certify that all quality concerns cited and fined have been addressed. This allows nursing homes to continue to meet high standards without losing staffing levels, which we know are critical to the quality, quality of care that a patient receives. Ms. Gould, given current staffing shortages and the disincentive to return to work due to some of the additional unemployment payments, would it be beneficial to remove barriers to in-house training for CNAs in nursing homes? And do you believe that this ability to train and make more staff available at these facilities is consequential in helping prevent the spread of COVID-19 in nursing homes?
So that's a two-part question. I do think that staffing is key to prohibiting the spread of COVID-19 in the nursing home. And like I said earlier, when you're running short or you're in a hurry, you make mistakes. And so having the appropriate staff on hand definitely would be an advantage. We actually do run in-house CNA training programs currently in our facility. We do that, and it does help with retention. I think where we see a real issue really is in the compensation rate. So being a CNA is hard. CNAs are required to bathe people, to feed people, to change them effectively. And so when you can go someplace like Target or Burger King and earn a wage that's similar, it's hard to compete. And I know in our facility, we are about 90% Medicaid. So I hear a lot of talk about the Medicare dollars, but for our facility, that's not where a lot of our money comes from. And so it's hard to continue to give increases when the Medicaid rate that you're receiving doesn't cover the majority of your costs. But I think what you're saying for other facilities, it is true. Having a CNA program in-house is beneficial. It allows you to train the people on site. It makes them comfortable, and it is easier to retain them. And so I do think removing barriers in other states in order to have a CNA training program in-house is valuable.
Thank you. Mr. Gould, earlier you talked about being able to track PPE and make sure that recognize that we have a different burn rate if you have an infection of COVID-19 versus not. Do you have any ideas in a short time about how we can more accurately capture that data?
So in New York State, we are completing a data set every day. It's called HERDS reporting. And on there, we do list our current burn rate and our current rate on hand, but there probably should be two different sections. One for what is your current rate for what you're currently using, and another one for what you would have on hand if your burn rate was that of having COVID positive patients, because there is a large disparity. I think it's somewhere between 3,000 to 5,000 masks a week difference between if you have a COVID positive patient in your facility and not having a COVID positive patient in your facility. It is a lot. You're required to change that mask every 2 hours if you have a COVID positive patient in your facility. So I think that is a great question. And I think that every state should be looking into that and making sure that in their FEMA stockpiles or your emergency preparedness stockpiles, you are prepared to move if a facility comes down with the COVID crisis in their facility. Great question.
Thank you for all your information. Mr. Chairman, I yield back.
Thank you very much. And I believe that concludes our questioning. I do want to thank all of our witnesses for a lengthy hearing, but a very insightful one, really an outstanding panel. I particularly want to thank again Ms. Satterwhite for being here. I know you made special efforts to get off work in order to be able to do this and rework things. And I saw the excellent profile on you that Avery Travis did on KXAN yesterday. Really, she's done great work also in exposing these problems, but your personal story really adds meaning to what we're doing today. Every witness made a big contribution, and members should be advised that they have 2 weeks to submit written questions to be answered. If you weren't able to get all your questions in today, those questions and answers will be made part of the formal hearing record. And with that, I believe our business is concluded, though our work to respond to this hearing is only beginning. So thank each of you, and that concludes our hearing.